Good morning. Welcome to the fifth meeting of the Joint Interim Standing Committee on Health and Human Services for the 2025 interim. Secretary, will you please call roll?
Senator Danyate. Here. Senator Lang. Senator Titus.
Here.
Assemblymember Edgeworth. Assemblymember Goulding.
Here.
Assemblymember Hibbets.
Here.
Assemblymember Nadeem.
Present.
Chair Brown-May.
I am here, thank you. As we begin this morning, I'd like to make several housekeeping announcecements. First, please silence your electronic devices. Honestly, I had to just silence mine, so please make sure yours are silenced. We're going to ask our presenters on Zoom video call to leave cameras off and microphones muted until it's your time on the agenda, and then we will direct questions to you at that time. Agenda items may be taken in a different order than listed. Two or more agenda items may be combined for consideration, and any item may be removed from this agenda or delayed. The committee's meeting material can be found on the Nevada Legislative website. You can also sign up for electronic notifications related to any activity on the committee's website. If you want to testify in person, please sign in at the table by the door and leave a business card. When testifying in person, please turn on your microphone to speak and off to listen, as we have folks that are listening online and in multiple locations. I would also like to remind our members, as we are participating today, that if you will turn your microphone on when you are speaking, it'll be easier to record, and then we'll be able to acknowledge you from both locations. So thank you to our members in the South. Secretary, anyone who is not here, please mark them present when they arrive or absent if we end the meeting and they have not shown up. This morning we'll move into public comment. Our public comment today will be limited to 3 minutes per speaker. Yes, you heard me today, 3 minutes. It's our fifth meeting. Staff will time each speaker during public comment to ensure that everyone has a fair opportunity to speak. In addition to testifying in person, members of the public may provide public comment in various other ways. They are all listed on the agenda. If you'd like, you can provide telephone testimony by dialing 888-475-4499. And then when prompted to provide the meeting ID, today's meeting ID is 860-2827-5330, and then press the pound sign when prompted. So we will start with public comment for those who are in physical locations. If you'd like to provide public comment here in Carson City or in Las Vegas, please come forward and fill the seats at the table. Thank you. We're going to go ahead and start here in Carson City. Thank you. You may begin when you're ready.
My name is Rachel Daly, and I have autism. Autism is a lifelong disability. I spoke at a different committee at the legislature last year. I told them that for 3 years I've not received all of my services. I'm back in 2026, and I'm still not receiving all of my services from ADSD, a division of Health and Human Services. When I ask for accommodations, they reward them and then reject them. In one case, they took a 911-word description of my disabilities and changed it to 55 words about 2 pieces of software. After several things like this, we filed an internal complaint. The investigator said she would not investigate. She said I could have a different investigator, but that never happened. Instead, ADSD told my advocate that if he came to any more meetings, he would be arrested. After a few weeks later, they said they were going to take another look at me. It looks like they might kick me out of ADSD. They said I was too ADHD and not autistic enough. They sent me an outdated policy to defend their decision. The old policy said autism and ADHD can't be together. Now, autistic people are known to have ADHD 70% of the time. The new policy says that new diagnosis must be considered. New regulations made that obsolete. On Saturday, I got a notice that they will evaluate me and that I will be kicked out of ADSD if I say no. The new notice doesn't mention autism but gives an entirely different reason. There is a law that says the state must communicate with me in a way that is effective for me. I don't think what they are doing is effective for anybody. It seems very wrong. Please help me. I think ADSD is violating the ADA, and it seems to be trying to coerce me to leave.
Thank you for your comments. Would you like to offer public comment as well?
Yes, I do.
Thank you. Go ahead.
Oh, wait a minute. Termination may occur when public conduct defames the agency, its programs, or its staff.
Sir, may I interrupt you? Would you please state your name
sorry.
for the record?
My name is Larry Daly, for the record, and I'm an advocate for a person with disabilities who happens to be my daughter sitting.
Thank you. Go ahead.
Termination may occur when public conduct defames the agency, programs, or its staff. ADSD's developmental services is mandating that its clients with disabilities agree with this statement. People with communication disabilities should not complain publicly if they want to keep their services. So I think it is incredibly brave that Rachel here addresses you this morning, and I hope you agree. Because this is public, and we are complaining. The ADSD document, 3 pages right here, says the way ADSD terminates people who complain, etc., is through their eligibility and intake process. Wouldn't that hide from reports to, say, I don't know, the HHS committee, the real reasons for abandoning people with disabilities? This document also says that people with disabilities and their advocates must not interfere with the staff's ability to provide care. There's more, but there's no time to present it. Rachel has not received all of her care in 3 years. She and I have consistently and adamantly stated that is wrong. Believe me, ADSC sees this questioning as efforts to interfere with them. They've said so in writing. This 3-page letter is ADSD demanding that people with developmental disabilities, communication disabilities, and so forth understand and agree to its term. They are to sign it whether they agree with it or not, or they will lose their services. Quote, refusal to sign may result in denial or termination of all developmental services, and case closure. In a weird twist, an ADSD person tried to get us to sign a new document yesterday. We pointed out that we'd already signed another version of the same document, and that he initialed it and signed it. He responded with this, and this is a direct quote, "I did that to appease you." So he said he signed it, but now he said it was only an act of an appeasement. That's her program coordinator. This is the same organization that wants people with disabilities to sign this. I doubt that they'll have the same forgiveness with that signature saying, oh, we were just trying to appease you. She's right. They said if I go, they'll trespass me. That's not the scary part. Their document where they threatened to trespass me for being her advocate said, it would be inappropriate for you to attempt to visit the offices of the governor or the DHS to seek to communicate about these issues in person. How can the ADSD tell me not to go to the governor's office? I thought this was a nation with a First Amendment and a 14th Amendment and an ADA. I feel like I'm in a third world country.
Thank you.
Thank you.
You have reached your 3 minutes.
That's fine.
You're welcome to submit additional comments in writing. We'd be happy to receive them, and I appreciate that
think
you're
the
here today.
point's made. Thank you very
Thank
much.
you.
Though.
Thank you so much. Seeing no one else here in Carson City wanting to offer public testimony, we'll go down to Las Vegas. You may begin when you're ready.
Thank you, and good morning, Chair and members of the committee. My name is Cassie Charles, here on behalf of the hardworking AFSCME union members. I would like to call this interim committee's attention to the circumstances and current working conditions at the Desert Willow Treatment Center, our state psychiatric facility for youth under the age of 18. Since July 1st, 2025, our AFSCME workers have been overwhelmed, overworked, and vastly unprepared for the implementation of AB 467, which passed during the 2025 regular session. The intent of AB 467 was to restore competency of youth going through our juvenile justice system so that they receive the mental health care they need and deserve to be able to not only have a fair judicial process, but to serve as an intervention in the lives of our youth who are potentially facing criminal proceedings. But while AFSCME workers at Desert Willow are some of the most skilled and compassionate workers in our state, they are not adequately prepared to work with forensic patients. Due to this, the workers at Desert Willow are consistently in unsafe circumstances, which have led to numerous worker injuries. Just last week, we had 4 workers injured in one shift. We have reports of broken bones, black eyes, and even injuries sustained from an attempted stabbing. To be clear, AFSCME workers want to provide the best quality of care to their patients and have restored several patients to competency despite the circumstances, but they are not being set up for success by the state or the agency. The passage of AB 467 changed the dynamic of the entire facility. Yet workers receive no updated training, regulations, or procedures for more aggressive patients. Currently, on any day shift, any shift at Desert Willow, you can see at minimum 5 workers on light work, which is essentially administrative roles meant for workers who are currently too injured to be working with patients. On top of that, you regularly have about 25 workers on each shift. With 5 on light work, you also might have 5 working a double shift so that they could be an hour 16, 17 of their 12 or 16 of their shift. And because they're either mandated to be there by their management or they chose to work a double shift voluntarily. On top of that, you'll have about 5 more who are choosing to work the shift after that. These are the perpetuated circumstances that are leading to harm in our psychiatric facilities, and our workers are at a breaking point. At other facilities meant to treat patients from our judicial system, they have specifically trained staff who do the patient management so that our nurses and social workers can provide quality mental health treatment. Typically, these positions are forensic specialists. They have an entirely different job description, qualifications, and training to be able to manage aggressive patients in a manner that is safe both for the patient and the facility staff. Without this staff, the workers at Desert Willow are essentially doing 2 jobs, 2 classifications, and serving 2 purposes at once. Today, additionally in public comment, we have 2 other AFSCME members. One is from Desert Willow, David, who'll go next, and then we have Jared from Stein Forensic Hospital as well to talk about the differences between the 2 facilities. And we'll go, David.
Good morning, committee. My name is David Gladden. I'm a member of the AFSCME Local 4041 and a mental health technician at Desert Willow Treatment Center. As a mental health tech, I work normally with young patients ages 6 through 17 years to ensure they are following the treatment plans to learn basic social and personal skills through emotional and behavioral regulation of self. I enjoy my work with these vulnerable population of neurodivergent and behaviorally challenged children working towards healthier lives. Our responsibilities as mental health techs is through positive behavioral intervention and support, as well as anger replacement therapy, teaching our young patients how to self-regulate their emotions, positively interact with others, and how to express themselves in a physically non-threatening way. At Desert Willow Treatment Center, our patients are either severely neurodivergent, have extreme behavioral challenges, or both. They require constant observation and monitoring with positive prompting and redirections. On any given shift, there are more patients in a unit than there are mental health techs, as there is no consistent staffing ratios. Desert Willow is consistently understaffed and is in its mental health techs and nursing personnel. Often nurses are asked to step into the role of mental health techs. Unfortunately, due to the aforementioned patient population of neurodivergent and behaviorally challenged patients, my work environment can become dangerous, and we cannot predict how or when a patient may be triggered by their peers or a staff's prompt or redirect into verbally or physically aggressive, violent behaviors or reactions. As mental health techs, we understand the challenges and dangers we may face on this job. However, AB 467 has introduced a different type of patient to Desert Willow that we mental health techs, and from my conversation with other staff nurses, cannot manage alone. AB 467 introduces patients with juvenile justice cases who are not the population the facility at Desert Willow was designed and or intended to serve, especially not with a goal of no physical restraint that is currently being implemented via the positive behavioral intervention support and anger replacement therapy programs. Forensic patients or juveniles with justice cases are typically more physically and verbally antagonistic, violent in their behaviors, thus requiring specialized supervision by forensic techs. In the last week or two, 5 mental health techs were assaulted and injured by 2 juvenile justice, aka forensic patients. The injuries range in severity from black eyes and bruised limbs to concussions and possibly fractured bones. This means that Desert Willow is now at least 2 mental health techs short, as they had to be placed on light duty, therefore unable to supervise patients or other psychiatric units. This is in addition to the other 3 or 4 techs already on light duty due to injuries from their juvenile justice forensic patients and or neurodivergent behavioral patients. So my colleagues and I are down at least 5 colleagues whose shifts we need to fill by either voluntarily doing double shifts or being mandated to a second shift, which means 16-hour shifts, operating under even more dangerous patient-staff ratios. AB 467 exacerbated an already unsafe work environment because its implementation came with no additional staffing, support, or preparation of staff to handle a mandatory intake of juvenile justice forensic patients. With the new administrators
Thank you. Thank you. You're over the 3-minute limit. If you will wrap up your comments and then submit your comments to us, those you have in writing, I would appreciate that.
Okay. So just to wrap up, I'm here representing my fellow mental health techs and nurses to request that this committee hear us and help us by working with us and our agency to implement solutions
Thank you.
Hello, members of the committee, and good morning. My name is Jared Klusner. I'm a member of ASME 4041. I'm also currently a psychiatric nurse working at Stein Forensic Hospital. Been working for the state about 13 years. So Stein is a facility that deals with the adult forensic population. These are adults under custody from correctional facilities like CCDC who are admitted for competency evaluation and restoration. They are most often there for violent crimes. These clients are kept separate from the regular adult mental health population of patients at Ross and Neal and Deanie Townsend psychiatric hospitals, also run by the state. Since AB 467 was implemented, youth clients from juvenile corrections have been placed at Desert Willow Treatment Center. I would like to share the story of one of my fellow AFSCME members from Desert Willow who was unable to be here to speak today. This member is a mental health tech working at Desert Willow. They did express that they understand the challenges of working at a psychiatric hospital, but they do find the work rewarding and appreciate the stability of a state job. While supervising a youth client, this employee was pushed into a room, beaten, and stabbed in the neck with an improvised weapon by a client. All the while, the client was yelling racial slurs, obscenities, talking about how they were going to kill the staff member. This employee barely escaped and was able to alert other staff who were able to then restrain the client and remove his weapon. So this attack could have led to life-threatening injuries, but fortunately, this particular employee was able to be successfully treated at a hospital. The employee stated that this particular client was admitted to Desert Willow for competency evaluation and restoration, so a forensic juvenile client. If they were an adult, they would have been placed on a unit that had forensic specialists who are trained to supervise individuals from a correctional setting where the frequency and severity of violence is substantially higher. Forensic specialists are trained to deal with correctional populations, and they are post-certified by a law enforcement academy. For as many issues as we have at Stein, and believe me, we have many issues, a lot of them related to staffing, we at least have forensic specialists that are trained and equipped to work with these clients that come from a correctional population. Because of AB 467, Desert Willow now takes these clients from these juvenile correctional centers, and this is a population that mental health techs are now being asked to supervise without the tools or skills to do so safely. We're not prescribing blame to the clients themselves, as they are potentially dealing with severe mental issues and behavioral issues and likely have a substantial history of trauma. And they deserve the best care available. But as an ASTU member and a state worker, I ask that the state properly fund Desert Willow Treatment Center to ensure that staff and client safety is made the priority. Thank you for your time.
Thank you.
Good morning, Chair Brown May and members of the committee. My name is Joe Engel, and I'm a founder and CEO of There Is No Hero in Heroin Foundation, a Nevada nonprofit behavioral health provider serving adolescents and adults since 2013. We started this organization after losing my 19-year-old son to a heroin overdose. Since then, we have spent over a decade building prevention, treatment, and recovery services in Nevada. For families, because we believe solutions exist even in the middle of a complex crisis. The data that will be presented here today confirms what providers across the state already know. Nevada ranks 51st in the nation for access to mental health care. More than 70% of the youth with depression receive no treatment, and Nevada ranks last in youth access to care. But I want to emphasize something important. The barrier is not a lack of commitment from community providers. The barrier is the system itself. Community providers are spending increasing amounts of time in managing administrative compliance across Medicaid, managed care organizations, certification requirements, and grant reporting instead of delivering direct care. The system is fragmented, duplicative, and difficult to sustain, especially for small and nonprofits working on the front lines every day. We know what many people in crisis need: long-term housing, integrated treatment, case management, and continuity of care. But trying to coordinate these services often feel like we're hitting a wall in every direction. We also cannot solve workforce shortages while burning out providers with fragmented administrative systems. If Nevada wants different outcomes, we must make it easier for providers to deliver care, not harder. We need coordinated systems, sustainable reimbursement, workforce support, and policies that reduce barriers instead of adding layers of administration. Organizations like Tin High are not asking for special treatment. We're asking for a system that also allows providers to spend more time helping people and less time surviving bureaucracy. Thank you for your time and for your commitment to improving behavioral health in Nevada.
Good morning, Chair Brown May and members of the committee. My name is Lee McAllister. I am the Executive Director of the Nevada chapter of the American Academy of Pediatrics. I'm here today representing our chapter's 290 pediatricians and the evidence-based medical standards they uphold. The American Academy of Pediatrics is the leading national voice for children's health. We continue to sound the alarm on the national emergency in child and adolescent mental health first declared in 2021. Nearly 5 years later, this crisis remains urgent, as you've already heard this morning and will no doubt hear from today's speakers. I have submitted a formal letter for the record outlining our priorities in relation to today's agenda. Thank you for your leadership and for your dedication to the health of all children.
Good morning, members of the committee. My name is Amanda Habish-Deloy, and I am from the UNLV Nevada Institute for Children's Research and Policy, and I also sit on the Clark County Children's Mental Health Consortium. And we just wanted to formally acknowledge that May is Mental Health Awareness Month, and last week just closed out Children's Mental Health Awareness Week, and we are very grateful that you took the time today to dedicate to listen to issues related to mental and behavioral health. As you just heard, we are often last when it comes to mental health services in the state, and we know that we have made great strides to try to make improvements. And as you listen today and in the following months and consider policy recommendations, just to ensure that we separate policies for children and adults, as they often need different things. And we look forward to working with you on those policies coming forward. Thank you.
Thank you. Seeing no one else here in Carson City or in Las Vegas wishing to offer public comment in person, we'll go to the telephone lines. ABH, is there anyone on the telephone who would like to offer public comment at this time?
Thank you, Chair. The public line is open and working, but there are no callers wishing to provide public comment at this time.
Thank you, ABH. We will officially close public comment and then move into item 3 on our agenda, which is our first presentation, the presentation on mental and behavioral health landscape in Nevada and the Western region, with a discussion on our current fentanyl epidemic here in Nevada. And we will invite forward Dr. Kellyanne Beavers with the Lindsay Institute in Brookings Mountain West to provide us with that presentation. Thank you so much for being here today. You are welcome to begin whenever you're ready.
Thank you. My name is Kellyanne Beavers, for the record, from the Lindsay Institute. Thank you, Chair Brown-May and members of the committee. I am the Community Outreach Coordinator, specifically at the Lindsay Institute here at the University of Nevada, Las Vegas. And I'm joined today by Kason Knoll, a researcher at Brookings Mountain West and the Lindsay Institute, and one of the lead authors on a fact sheet that forms the foundation of this presentation about the state of mental health in America and in Nevada. I'm going to turn it over to Kason first to walk the committee through our data on the state of mental health and behavioral health in Nevada. And then I will follow with an overview of current interventions, emerging challenges, and recommendations for next steps.
Good evening, Chair and members of the committee. My name is Kason Knoll, for the record. So this presentation is going to draw on data and analysis from the Lindsay Institute and Brookings Mountain West at UNLV, adapted from Mental Health America's 2025 national report. So what you're about to see here is not just a snapshot of where Nevada ranks, but rather an explanation of why Nevada keeps ranking at the bottom and what that truly means for Nevadans. So this presentation is going to focus on Nevada-specific data about adult mental health, youth mental health, workforce availability, as well as insurance access. And so if we look at the state of play here, we see that at the top, Nevada, of course, ranks 51st, as many of the people here will tell you today. That means that when Mental Health America evaluated all 50 states, in addition to Washington, D.C., on 17 different measures of mental health performance, prevalence, access, workforce, and insurance, Nevada came in last. Not last among Mountain West states, last in the entire country. Additionally, there's federal context here. As House Resolution 1 was signed into law, Nevada is projected to lose hundreds of millions of dollars in Medicaid funding as a result. More than 147,000 Nevadans who currently rely on Medicaid for mental health and behavioral health services are at risk of losing that coverage. The largest cuts don't take effect until 2027, but Nevada is already feeling the pressure and needs to be preparing right now. Now, I want to take a moment with these numbers because they're really easy to move past. First, 1 in 7 Nevada youth have had serious thoughts of suicide in the last year. Additionally, nearly 60% of Nevada's youth who experienced a major depressive episode last year received no mental health services at all, meaning that most young people in this state who needed help did not receive that help. Additionally, for adults, nearly a third of Nevadans living with mental illness cannot access care, showing some clear disparities between mental health prevalence and access. Now, something that gets lost in how we talk about mental health policy is that substance use disorder is part of the exact same conversation. In fact, federal law actually requires it to be treated that way. Substance use disorder, or SUD treatment, is listed as an essential health benefit, the same as mental health care is. But in practice, these often are treated as separate problems with separate budgets and separate programs. Nevada's rate of adults living with substance use disorder is above the national average. The same workforce shortage, the same insurance barriers, and the same gaps in care affect both of the populations. You can't meaningfully address one of them without the other. Now, this slide might feel like it belongs to an education presentation, but it's one of the most important pieces of data that we have on the mental health crisis in Nevada. Specifically, Nevada's chronic absenteeism rate is 25.6%, where specifically more than 1 in 4 students are missing out on enough school to be considered chronically absent. Additionally, Clark County is even higher at 27%. Mental health is clearly a leading driver. Students who feel overwhelmed, unsafe, or are bullied end up not coming to school. The impact of bullying on absenteeism has nearly doubled since 2013. That immediately tracks with the rise of social media and artificial intelligence, as well as the mental health challenges that have come alongside it. Without counselors and crisis support to intervene early, absenteeism turns into dropout, and dropout has lifelong consequences for that student, for their family, and for the future of Nevada's workforce. Now I'm going to turn it over to Dr. Beavers for an overview of current interventions, emerging challenges, and recommendations for next steps.
Thank you, Kason. My name is Kelly Ann Beavers for the record. I'd like to start by talking with you about mental and behavioral health parity. Federal law prohibits insurers from imposing greater restrictions on mental and behavioral health benefits than they impose on medical and surgical benefits. This means the bar cannot be higher for mental health with respect to how insurance plans are covering care. In Nevada, it is. The Division of Insurance's 2025 report found that at least 16 insurance carriers, are likely in violation, meaning that in practice, they're requiring prior authorization for mental health services that are not publicly listed as needing prior authorization, and/or they are denying requests for mental health coverage at higher rates than they are for physical health claims. This means that a Nevadan seeking mental health care is being held to a higher standard than someone seeking care for a physical condition. In addition to workforce shortages, Nevadans are being obstructed from care and providers are not being paid for services provided as a consequence of this reality. AB 207 does now require carriers to be publicly named when they're out of compliance. That transparency matters. But knowing who is violating the law does not mean anything if the consequences don't change behavior. And Nevada's current fine cap does not do that. And I will come back to that later in the presentation. Next, I'd like to talk about the workforce gap and its relationship to graduate medical education. To understand the workforce gap, you have to first understand what it takes to get licensed. Graduate medical education is the supervised training that clinicians must complete after their degree before they can practice independently. For psychiatrists, for example, that's a 4-year residency. For psychologists, counselors, and therapists, it's thousands of supervised clinical hours in approved settings. None of this happens without funded training slots. The critical problem in Nevada is that supervised training requires approved sites and licensed supervisors, and Nevada has historically had very few of either. And when trainees cannot find placements here, they end up leaving the state to complete their training, and providers practice where they train. It's important to be aware that this aspect of graduate medical education is an aspect of the workforce gap, in addition to the aspects that we may talk about more frequently with respect to workforce shortages. SB 165 did make a difference in this last session. Before it, we had no APA accredited child psychology internship program at all. So we did not have a gap in recruitment. What we have is a gap in infrastructure. SB 165 has begun to fix that, and sustained graduate medical education investment is how we can stop exporting our trainees to other states. The Lindsay Institute is also here to support the committee and the chair with further understanding of research about this specific topic. I next want to talk about current initiatives to emphasize that Nevada has not been standing still. Nevada has been working hard and has been dedicated to specific nuanced initiatives to make changes. Two of these are indicated here. One is Be Here Nevada, which stands for Behavioral Health, Education, Retention, and Expansion Network of Nevada. This program reaches K through 12 students and adult learners across Nevada, connects them to training pathways, and works to retain graduates so they stay and practice in Nevada. But this program will require sustained investment to deliver on its long-term goals. Another example is the practice at UNLV, which provides low-cost, evidence-based mental health services to the community while simultaneously training the next generation of Nevada's mental health workforce. It accepts Medicaid, which is critical for access. It is both a service delivery mechanism and a training infrastructure. But again, an immense amount of work has been done by the legislature and by community leaders to establish both of these initiatives. And going forward into the next session, there will need to be a sensitive attention to care and detail to ensure that these initiatives are maintained. I want to briefly talk about the 2025 session. I mentioned previously that AB 207 requires the Nevada Division of Insurance to publicly document insurers that are out of compliance with federal mental and behavioral health parity requirements. Additionally, I've touched somewhat on the effects of SB 165, a very important part of the 2025 session that we all should be incredibly proud of and committed to continuing to refine and invest in following up on. It established the first, as I mentioned, APA accredited child psychology internship program. It created a new behavioral health and wellness practitioner profession, and it directed nearly $6.5 million to various institutions of higher education to build behavioral health training pathways. An important aspect, I feel, of our presentation is to offer you examples of ways that we can learn from other states about mental health parity. Other states show us what meaningful enforcement looks like with respect to fines on insurers or placing an undue burden on mental health care and mental health providers. Maryland's approach is particularly instructive and actionable because they do not require proving harm. So as you consider ways to create meaningful enforcement going forward, they have adopted stricter requirements for insurers' parity analyses so that a failure to submit information is a baseline for a violation rather than a complaint having to be filed and then harm having to be proved, et cetera. It simplifies the process. I also want to emphasize that our current cap on fines for insurance carriers is $50,000, as in ever in total, not at one time. If Nevada providers cannot get paid by insurance providers, then they are going to opt for cash payments, which reduces access to care and will discourage providers from practicing in the state. Nevada raising or removing the fine cap is a concrete policy lever for making parity enforcement real in this state, and other states have given us great examples to follow in terms of how to improve on what we started last session. Our current cap is not a deterrent. $50,000 is a cost of doing business for large insurance carriers. We must reconsider how to be more aggressive and simplify the process administratively for the Division of Insurance in order to follow through on this. I'm going to move on to my next slide, which has to do with other challenges that have emerged with respect to mental and behavioral health at the state level. So we can see the implications of what is happening at the federal level as we look at consequences that our the programs that we have previously invested as a state and an incredible amount of energy are now having to reduce or cut back. Nevada 211, for example, has had to reduce its call center hours. It's closed on weekends and holidays. This limits access when many of Nevadans are facing their most acute needs. And this is a consequence of limited funding and cutbacks that have impacted Nevada 211. So I would encourage you to think strongly about how to invest in Nevada 211 going forward and or provide support for this purpose. Federal funding disruptions have also ended some of the UNLV practice programs. So programs serving rural youth and at-risk youth in Las Vegas. Some of these programs that are led by UNLV practice are being affected by federal funding disruptions. And it's important to be aware that while as a whole, the UNLV practice continues to do incredible work, it is necessary for there to be attention given to these challenges that are emerging. Also, Be Here Nevada's workforce pipeline that I mentioned earlier will depend on sustained state investment to deliver on its long-term recruitment and retention goals. And again, the Lindsay Institute is here and available to the committee and the chair if it is of value to think through specific ways to continue sustaining this investment. I am going to wrap up my portion of the presentation by talking about the policy recommendations that I can offer you briefly at this time. I've gone through these already, but just to summarize. We recommend that the state of Nevada begin to enforce parity with greater teeth. So the $50,000 fine cap that was established last session to ensure that Nevada insurers prioritize mental health claims needs to be reevaluated. And to do that, we can follow the lead of other states like Georgia and California and Maryland. Another recommendation is for us to protect vulnerable funding, especially for programs that are at greatest risk, like rural telehealth, youth mental health, 211 crisis services, and other services that support Nevadans with the fewest alternatives. The Medicaid funding reductions coming in 2027 and 2028 are foreseeable and catastrophic. Nevada can act now rather than responding in crisis. A third recommendation is to scale the pipeline. Be Here Nevada and the graduate medical education investments from the 83rd session are foundational. The state must move from foundational funding to sustained multi-year investment. A provider to patient ratio of 1 to 400 does not improve without long-term commitment. And I commend the state and the leaders in this committee and in other aspects of government who have worked really hard to work toward shifts in this area, and we recommend a continued effort to do that. The last recommendation that I'm making here is to support integrated solutions. Especially, I'd like to gently point back to the slide that Kason presented earlier about substance use disorder and how to conceptualize single unified policies that acknowledge that these are not two separate policy lanes. These are a policy lane that has to do with mental and behavioral health and substance use disorder. Thinking about this critically, especially with respect to Medicaid, will help our leadership better reimburse the treatment providers in such a way that is conscientious of it being a healthcare provision, and in that way acknowledge the requirements of parity and ensure that insurance carriers are abiding by those requirements. Thank you very much for your time and attention to the information we've shared, and the end of the presentation does provide you with specific references. If you'd like to follow up on those, we're also happy to coordinate times to chat with you further about this.
Thank you for the presentation. Members, questions? I think you've stumped us this morning, Dr. Beavers. Thank you.
Well, we will continue to be here and present for you. Thank you all for your leadership.
Thank you. I do appreciate that you are here. I think the information you presented is very clear and concise. I especially appreciate the recommendations. And I do want to call out your co-presenter this morning. I do understand that Mr. Knoll is also a youth legislator that represents Senate District 5. Is that correct?
Yes, that's correct.
Thank you, youth legislator. It's very nice to have you here with us this morning, and I appreciate your presentation. Okay, seeing no questions, thank you so much. We will close the presentation, agenda item number 3, and move to our next agenda item, which is the overview of the opioid and substance use environment in Nevada, including treatment organizations, outcomes, and medications for opioid use disorder. And we will welcome our presenter, Mr. John Firestone, President of the Nevada Opioid Treatment Association, and Dr. Dinta Smith, Vice President, for the presentation. You are welcome to begin whenever you're ready.
Good morning. And thank you, everyone. I would like to say thank you to the Madam Chair and members of the committee. My name is Dr. Dinta Smith, and I am a director of one of the opioid treatment programs, and I am also the vice president of NODA, which is the Nevada Opioid Treatment Association. And I want to say I thank you all for allowing us to be here. So I'm here today to address the opioid crisis. And NODA represents 13 clinics throughout the state of Nevada. And in our clinics, we treat 4,500 to 5,000 individuals, okay? These individuals they have been diagnosed with an opioid use disorder, but we also manage individuals with substance use disorder. We provide comprehensive services. We have doctors, nurses, RNs, LPNs. We have nurse practitioners. Our counselors are certified and licensed, and we provide counseling services as well as medical treatment. Now, NODA, our goal is to advocate for services to enable us to improve the treatment services that we provide to our patients. We do accept private insurance, Medicaid, and self-pay. How do I move it? Okay. We do treat individuals 18 years and over. However, there are clinics that is licensed to treat 13 years and over, because we do know now that the opioid crisis does not only affect adults. You know, we are seeing an increase in opioid use. 95% of our patients are self-referred, and so they aren't mandated in treatment. We do have some clinics that are connected to drug court. Those individuals are mandated, but the majority of our patients walk through our doors seeking treatment. And OTPs, which are opioid treatment programs, is a level of care that's often misunderstood, and it is also underfunded. We provide 50% of all direct opioid treatment services to Nevada, the Nevadians. And, you know, with 55 to 66% of OTP patients, they discontinue their use of opioid use at 6 months. And then 52 to 57% of those individuals remain in treatment. So, you know, we are providing a medication for opioid use disorders that helps patients or individuals discontinue their use. And so we are on the forefront of fighting this opioid crisis. And I think this quote here below says it all. We serve brave individuals who want a different life, not only for themselves, but for their families. Now, I spoke to you from a professional standpoint. This video that I'm about to show are individuals who have lived experience. And although they represent one of the 13 OTPs, We all have individuals who would be more than willing to share their life experience with you all and share how they feel that the opioid treatment programs saved their lives. So if we could start the video, please.
It'd be really easy for me to start every single one of my children's stories off with my mom was a drug addict and she died. And that's it. No one would know anything about me or who I was. They would know that I was a drug addict and I died. And that's then my children's story. And whatever trauma they get from not having me there. So, yeah, it's a really big eye-opener.
So many times you go down that hole, and at some point you realize that you're here for some reason. I got introduced to addiction via prescription painkillers.
What started is, of course, coming from a very dysfunctional family. I've had an addiction and a problem for probably about 20, 30 years. I wanted to change. I wanted to stop taking pills because I got tired of being sick.
My mom and my dad, they both cooked methamphetamines, kind of like led me into the life of selling drugs. And of course, when you're selling them, 9 times out of 10, you're doing them also.
State-raised, foster homes, group homes, institutions. So I was a street kid by the time I was 12, and I started doing heroin.
Since I was old enough to make my own decisions, I did drugs. My mom and her boyfriend were dope cooks. We're from Oklahoma, so it was meth. $350, $400 a day habit, and just kind of ran with it.
I had a really good life up until I was about 21, 22 years old. Went through addiction kind of late in my life.
Every time I went to prison, it was drug-related or alcohol-related. There's a way out. There's a better way out.
I knew I needed help, so I came here.
That was one of the things that I had to do was seek out a counselor, and the Life Change Center was where they suggested.
I just decided I wasn't going to let drugs take anything else from me. Once I decided to work steps and I didn't want to be a drug addict, it was everything. I never could picture myself living a sober life. Like I've just begun to live this last 3 years.
No matter how many times you came back, you were always welcome back.
Thank you, Madam Chair. Thank you, committee, for having me here. My name is John Firestone. As mentioned before, I serve as the president of the Nevada Opioid Treatment Association. I'll be referring to that as NOTA. I really do appreciate and recognize the opportunity that you've given us to be up here today. And I want to share that I'm very proud to be doing this work. I mean, that video really represents well what it's like to be on the front line of this opioid epidemic. So to talk about substance use disorder in today's world, we can't have that conversation without talking about fentanyl. Fentanyl has completely changed the landscape of what it's like to do substance use disorder treatment and for what it's like to use substances in today's world. The data points you see up here, it's like almost exaggerated, but they're not. Fentanyl is literally 50 times stronger than heroin. Now I'm going to date myself a little bit here. So I was doing service work back in 2000s, in the early 2010s. At that time, when an individual walked into one of our clinics and asked for help, their stated problem was heroin. This was like a full alarm situation. This was high acuity. We would do anything and everything, bend over backward to make sure that that person would get in immediately. This was like the most scary moment. Here's where we are today, and I'm not exaggerating. If a person walks in today and tells me that they're using heroin, I'm relieved. I feel that they're safe. As I mentioned, the world has entirely changed. And besides being exceptionally strong, it's also taken over. So one of the problems that we see with fentanyl, it doesn't just come in small like chunks, it takes over. So people that are using opioids, especially those that have a substance use disorder related to opioids, their choice of opioids are restricted primarily to just fentanyl. So people even buying heroin will likely be buying a powder with fentanyl in it. People that are buying pills are likely buying a pressed pill with fentanyl in it. Almost everything is fentanyl. It completely takes over, and this makes sense because the fentanyl strength is also related to its size. So just for an example, perhaps if there was a police seizure of 10, maybe $15 million worth of heroin, that might be something on the size of a pallet, which is what, 4 by 4, but it would be about 4 feet tall. Just picture that in your head. That same amount of street value of fentanyl would fit in a shoebox. Something the size of a tennis ball would be worth about $1 million on the street in fentanyl. It takes over completely. So Nevada's really not doing that well. The state's a little bit about what's going on in terms of how we're responding to this crisis. The overdose rates are going up. The ER visits are going up, while the rest of the nation, we see it going down. These are tragic statistics, but there is a way through, and I do want to make sure I'm going to bring up a lot of negative things, but know that at the end of this, we're going to give some recommendations, okay? The administration is brought up. This is a paper from our administration, some good points. I love this slide. It shows where they're addressing substance use disorder as a chronic and treatable disease, and that's a really important piece. Sometimes it's overlooked. It brings up that there's a ripple effect, that it's not just about overdose, death, and treatment admissions, criminal justice. It includes things like homelessness. It includes a lot to do with our workforce. This is decreased workforce participation and loss of productivity. These are huge factors in the whole thing, but also families and generational problems that come from that. There's a lot, and it's brought up in this letter. They also mention in this letter that substance use disorder treatment should be parallel to other chronic diseases and how they're treated, and rely on evidence-based approaches. And I'm proud to say that MOUD at OTP is considered the gold standard for care for opioid use disorder. It's been supported by decades, almost 60 years of research, showing decreases in overdose death, illicit substance use, particularly opioid use, infectious disease transmission, criminal justice, family welfare cost, and health care. So thinking back to Dr. Smith's presentation, she mentioned some things that I don't know if it all resonated, but it's very important. I want to retell those statistics, which is that a person in treatment or an OTP is between 13 and 14 times less likely to die of an overdose than somebody using opioids not in treatment. Please consider that for a second. That a person entering an OTP in our state is over half of those people are likely to still be in treatment at 6 months. And a person entering an OTP in our state at 6 months, nearly 60% or sometimes even over 60% of those people have discontinued their use of illicit opioids. This is kind of a heavier conversation, but it's part of the conversation. There's a lot of costs associated with opioid use disorder. You'll see here that there's two parts. Actually, there's 4 parts, we should say. There's 2 parts, the United States and Nevada, so we'll focus on Nevada. The upper section talks about those who live, right? This deals with health care, substance use treatment, criminal justice. And the lower part, which is larger, deals with those that did not. There's substantial cost to our system, and these costs do not address the largest part. The largest impact we have of cost deals with loss of productivity and decreased entry into the workforce. We're losing people, by the way. It's different. I know that like tobacco is a big problem, but we'll see a person that may die of a tobacco-related illness at the age of 70 after working for 40 years. The highest level of people that are dying from an opioid overdose are between 18 and 44 years old, at the prime of their life, and we're losing everything that they could bring to that table. Just making sure I'm not forgetting anything. I got notes. Tried not to use them, but I'm not that good. So First of all, I want to thank you all very much. I know that you were involved with the passage of SB 300. This raised a rate that we had for medication administration from $3.94 up to $10 a day. This is important. One is because that rate of $3.94 was established in 1980. Our providers have been operating on funding that was established in 1980. The $10 a day, which will kick in on March 1st of this year. It hasn't yet. We're still waiting for things, but I won't go down that rabbit trail. Will bring us up to a higher level. And what I can tell you what's great about that, there's some bad news too. I mean, one of the things is one of our providers did not make it. They couldn't hold out till March 1st, and we did lose one of our OTPs this year because they couldn't make it till March 1st. The $10 a day will guarantee that we will not lose another OTP, at least not right away. And it will ensure that we'll be able to retain our current staffing. However, the $10 a day is only bringing us up to a level comparable to like 2006, 2005. It still makes it tough for us to meet our capacity. Please remember that there's 13 different clinics in our state. They're distributed in such a way that 90%, I can't speak, 93% of Nevadans are within a very short drive to accessing MOUD, which is the gold standard of treatment for this health crisis that we're in. These 13 clinics can have more capacity. They can get more staffing. We need to have more money. That's how we get there. I know money's a difficult conversation right now. It really is. And we recognize that. So I do want to leave this with some recommendations. And if it's okay, I'm going to cover a few of these. I'm going to turn it back over to my co-presenter down in Las Vegas. The recommendations on how to get there, because it's easy to ask for money, but we believe we have a way that we can get through. So currently there's monies coming in from an opioid settlement. Really, OTP are one of the primary targets, or they should be, for that opioid settlement money. We are the primary caregivers of those with an opioid use disorder. We have our finger on that pulse. That money can be used, we've opened up some conversation to sort of help fund this, whether there's going to be different vehicles to get us there. We believe that maybe through supplementing like Medicaid, that is something that could happen. There's other avenues that we can take. But this would empower those 13 clinics to really open up the capacity, because we could save a lot of lives and save a lot of money and a lot of heartache if we could do that. Let me guarantee you that. It looks different. I can tell you that all the data, it looks different when you're like holding a grieving mother that's telling you about the loss of her son, right? So it is important. It is more than just the money. Another thing that we could do, I don't know if you guys are familiar with the term bundling within Medicaid, if that's something that we could look at a policy to promote that. What that allows us to do, as opposed to hiring more and more billers to get our work done and get reimbursement for our work, we can direct that money towards direct care staff. And I would like to turn this back over to my co-presenter down in Las Vegas for the final piece.
Thank you, John. And also what we could do to fight the opioid crisis is to require discharge collaborations between hospitals and ERs. We have a lot of individuals seeking medical treatment who have an opioid use disorders, and to provide a warm handoff. And that's the same, that's similarly between jails and correction facilities. I know right now there is buprenorphine or Suboxone being offered in correction facilities, but let's not discriminate on the type of medication that's there to treat opioid use disorders. So if we could collaborate care and collaborate a discharge, it prevents individuals who from having a break in treatment and returning back to the street. And although John said, like pointing out that fentanyl is real, it's real. And yes, we aren't seeing much heroin overdoses or individuals seeking it for heroin, but we are looking at fentanyl and xylazine and everything. So if we could coordinate this care, it would definitely reduce our opioid overdoses and ensure that the patients that are seeking treatment in the ER also receive it in the community when they're discharged. So thank you all for listening to us. We appreciate your time. And we encourage you all to come visit us.
Thank you. Thank you for the presentation. We do have a couple of questions. We'll start with Assemblymember Goulding.
Thank you, Chair. Thank you for the presentation. I'm wondering if we can go back to the $10 and if you can break that down a little bit. What does that $10 daily, so that's the reimbursement rate for Medicaid, right? For daily treatment. Can you unpack for us what all is included in that $10?
Sorry about that. So the $10 is
If
for
you'll state your name for the record every time you turn the microphone on, it will very much help our secretaries.
Thank you very much, and I'm sorry about that. I'm John Firestone for the record. The $10 a day is for medication administration. So one of the primary roles that an OTP serves is to give structured access to medications for opioid use disorder. That might be buprenorphine, which is sometimes known as Suboxone, or methadone. Those are the two most common prescribed. So the $10 a day is for that particular service. And it currently costs more than that to deliver that service.
So that's the administrative cost plus the medication.
For the record, this is John Firestone. Yes, that is for everything that's not counseling, everything that's not a doctor's visit. It's really for all things that get the medication to the individual.
Do you know what the average, the national average would be for that same coverage?
John Firestone, for the record. Yeah, it's about $17. The Medicare rates for that is $270 a week.
Thank you. Separate question. You talked about capacity. You said that the clinics have the capacity to expand. Can you unpack that a little bit? We hear all the time about workforce constraints, but I think I heard you say that that's not the constraint for you. You've got professionals that you could hire, and you've got the capacity, like the physical capacity, I'm assuming, in your in the clinics. So is it strictly a financial constraint that is prohibiting your clinics from treating more Nevadans?
John Firestone, for the record. Yes, so there's two parts to the financial constraint. One is staffing, and one is hours of operation. So what we can't do is extend past a certain sort of threshold of cost, or we start, obviously it becomes a non-equitable business, and regardless of being a nonprofit or a social service enterprise, it will fail. So if we had more money, what we'd be able to do is hire more staff. This is very important because we can increase not only capacity, but the quality of services and programming within those facilities across the state. And we could increase the hours. We can increase the amount of which the doctors, by the way, are related to the intakes. The more time we have with a physician that's on site, the more we can get people in that front door.
Senator Donyate.
This is the doctor. I would like to comment on that also. Dr. Danita Smith.
Go ahead, Dr. Smith.
Also, it would also allow us to hire individuals at a comparable rate. Because remember, we are competing against hospitals and other facilities. So it would not only allow us to increase our capacity, but also to have individuals that that are professionals and we can afford to keep them there.
Thank you, Dr. Smith. Senator Donyate.
Thank you so much, Madam Chair, and thank you so much to the presenters. Listen, I understand the reference in terms of increasing reimbursement. That's not the line of questioning I had, but just understand that as committee members, we're going to be dealing with the repercussions of HR 1 that we covered last meeting, and so it's going to become more and more challenging for groups like yours to come in front of us, and so just keep that in mind as we're going through it. If there's specific circumstances that your coalition can build in terms of what's the highest priority to the least level priority, that would be helpful for us as we go through this process. But one of the things that I wanted to touch point is your last recommendation dealing with the discharge collaboration between different entities. This is something that I was looking at adding in terms of an amendment to SB 54 that was passed last legislative session, which is in healthcare, it's so decentralized that because everything is based on a referral, right? One person refers to another. The continuity of a patient's care is, in a way, everyone's problem and no one's problem. And so I wanted to know, so one of the challenges that we were facing last legislative session was when you say that there should be discharge plans required for the transition of care, I guess the question becomes whose authority is it to manage that person's care delivery, and who receives the punitive measure for when that patient is not being taken care of? So I guess the question is, if we do require a discharge plan, is it on the provider? Is it on the hospital? Is it on the MCO? Whose ultimate responsibility is it to ensure and enforce that the discharge plan is being followed, so that the collaboration is actually set between your group and the hospital and the MCO and the county?
Dr. Danita Smith again. I think it's a combination. I don't know if it's a singular responsibility. I think that it's important if we're all there together. It's like case management. You have everyone that has a specialty on board. And so the hospital provides the OTP with a warm handoff. There's social workers involved. We as OTP providers, we will immediately call the insurance carrier. We'll get the prior authorizations, and our goal is to maintain those patients in treatment. Do we capture everyone? No. But I think to fight this opioid crisis as we continue to do so, if there is a warm handoff, a telephone call, we have after hour services that you can call and we'll be prepared for that individual. So I don't think it's just one singular person. I think because we are in a crisis in Nevada and there's so many people involved, if we all treatment providers work together, we can fight this.
Well, and thank you so much. But let me clarify my question, right? Ultimately, right, all of you are getting paid, whether it's the MCO, whether it's you as a provider, as that patient is navigating care, whether it's if they're outside, EMS picks them up, EMS takes them to the hospital. Hospital does some level of billing or probably discharges them. Patient then gets referred to your facility. My question is, if all of you guys are getting paid as part of the system of care for that patient to receive whatever level of treatment, how do we ensure, if we're going to be implementing your recommendation for developing discharge plans and so forth, I don't want a warm handoff. I want folks to be held accountable that you're not going to be discharging a patient if there's no actual discharge plan to be followed. And so I guess my question to you is, how do we ensure that the providers are actually being held to account, that we're not discharging patients when there's no level of transition plan in place?
So probably the best model that we can refer to would be what's called the Bridge program. I'm sorry, John Firestone, for the record. Keep screwing that one up. The Bridge programs sort of allow for that. What you're talking about, consequences or some sort of actions that can take place because of some sort of, I don't know what term you might want to use, but not following through with the treatment plan, that is something that would probably take some discussion to really build that out appropriately. But there are models in place. There's models that other states are using. It's nothing that we really have to reinvent entirely. But no matter what, it would be something we would want to look at over time. Thank you.
Thank you. And that's exactly what I was trying to get to. I think you all as an association need to work between. So obviously we're going to be working as committee members, we're going to be approving the bill draft request and so forth. But the answer that we need, the reason why I was asking that is the answer that we need is, how are you all going to actually coordinate with one another, right? Are you all using the same eligibility system? Are you all using the same tracking system to help navigate for if a patient that we haven't had contact for 2 years, but we know is a high utilizer in the emergency room? What are you going to do to navigate that process, and who's going to be ultimately responsible for it if someone's collecting a paycheck from the government, right? And so that's kind of the recommendation that we need from you. And so hopefully you can take some time in the next 2 months to discuss what it will take to actually get to that point. That was the reason why I was asking that question.
An excellent point. And it is our anticipation, and we appreciate your motivation, to reach out to the Nevada Hospital Association and the ER doctors, for example, to really discuss explicitly discharge procedures from the emergency room. The other good news is that peer recovery support specialists are becoming better trained and more available in our state. They are something that can be funded by an OTP. So we have a few more opportunities to create that bridge, but we get your message very strongly about clarity of discharge planning and not double paying for it, but expectations and accountability. I will just say one of our NOTA members has pointed out Clark County jails, for example, are very good, CCDC, at providing medications while a inmate is there and necessary, but they discharge at 2 a.m. So that's the kind of thing that we have to have conversations about, so that either there is a clinic that can be open 24 hours to have that direct handoff, or that discharges are at a time where the person can now go and get their MOUD. So these are discussions. We appreciate your motivation. Thank you.
For the record, this is John Firestone. Senator Donate, I would invite you to participate with a NOTA meeting. I think that you have some history looking at that, and we would love to hear your input on this.
Thank you. Next question from Assemblymember Nadeem.
Thank you so much, Madam Chair. My question is regarding the fentanyl, why it is easily accessible and why its use has been increasing day by day, and what we can do to contain it.
For the record, this is John Firestone. Thank you for that question. That's actually, I think, the question, and we don't have an answer for this. This is a collective approach. When we look at stopping fentanyl, we're looking at how can we change the availability of fentanyl. This is going to deal with increasing treatment opportunities. This is going to deal with criminal justice activities. This deals with, in terms of the overdose, in the response to overdose, the continued access to the anti-overdose drug Narcan. So I wish I had a set of steps we could take that would decrease the access to fentanyl. We do know, however, as OTP, ways that we can help people that are presenting for services to discontinue fentanyl.
Thank you.
Thank you. Next, Senator Titus.
Thank you, Madam Chair, and thank you for being here today and what you are doing for our state and helping. It is very discouraging to know that nationwide there's been a decrease in overall fentanyl deaths for the last 2 to 3 years, but yet they are increasing in Nevada, so that's discouraging. My question is really around that statement about in the future required discharge collaborations. It bothers me, and it's a concern that I have, that government gets involved in mandating how we practice patient care. And as a physician, it's up. I've always followed as a family practice person what the gold standards are within our practice and what the recommendations are, but not through government mandates. And so are you looking at us in a potential BDR saying you will have collaboration? And then how do you even define all of that? So that's a concern I have, because I would say that probably your own profession says that you should have collaboration already.
Thank you, Senator. Was that a question for the presenter, or was that a question for Senator Danyate?
Well, it's actually a kind of whoever wants to grab it, because I think we're on both sides of the aisle here. I would ask the presenters if they don't already have professional standards on their practice, and the importance of warm handoffs. That's a discussion we hear time and time again. So I know in family practice we have regulations, and I'm just wondering, I would assume that you already have requirements that you have warm handoffs and certain obligations as a professional that you already have.
For the record, this is John Firestone. Thank you very much for that question. Another very complex question. In fact, it's best practice to have collaborations. I know of working also in an OTP, we have multiple collaborations that we rely on. They're nurtured, they take time, they take energy, but they don't have, as one of our previous presenters mentioned, they don't have teeth. When Sarah Adler had mentioned just a minute ago that there are some people being discharged, for example, from jail at 2 o'clock in the morning without proper coordination of care, could those issues be something that we address? That's something we could look at. There's times when people might leave a hospital, same thing, people are free to leave, but maybe there's a way that we can coordinate care better. Is there a way that we can incentivize and or mandate certain contacts when people are presenting for a reason? That reason might be, or should be, opioid use disorder driven. Now, certainly there's a lot of work that we can do to sharpen our pencils around how we're looking at this and what we're asking for, and we look forward to working with Senator Donate in the future and hearing what you've done in the past and trying to structure that. So hopefully that's at least an attempt to answer your question.
Just a quick follow-up, Madam Chair. And so we already practice what's called, we're obligated on something called a safe discharge. And so at 2 o'clock in the morning, we cannot just discharge from our ER somebody out to the street that's not a safe discharge. And so I just want to make sure we're careful moving forward in this committee to address my colleague that we don't put more onerous regulations in that we can achieve in the state. And so again, the whole safe discharge is a critical conversation. So thank you for bringing it up. Thank you. Thank you, Madam Chair.
Thank you, Senator. Thank you. I do want to clarify, I believe the 2 a.m. discharge is from a corrections or detention facility. So it's when someone has been held in a corrections facility that there's a 2 a.m. release. Just to that is clarity. So we're getting yes head shake. So we're not discharging from a hospital setting at 2 a.m. without a warm handoff. So just leave that. Okay. I do want to, I have a couple of questions and have just come back from a national training relative to substance use and opioid use disorders and the treatments. And I just want to suggest that you do a little bit of research around a DART team, a DART model, which is a drug assistance policing model where there are cooperative teams with organizations like yours working with policing so that there is a warm handoff at a 2 a.m. discharge out of a detention center in order to get people into recovery. And so know that that's there. My question is really relative to new overdose medications, right? New drugs that are out on the street. And I'm curious to know, while to the Senator's point, our numbers are continuing to increase here in Nevada for overdose. Are there new drugs that you're seeing that are more powerful than the previous drugs, and what are we doing to address that currently?
For the record, this is John Firestone, and Madam Chair, thank you so much for that question. This is an important question. I've been doing this for a long time. I watched fentanyl come to Nevada. We spoke with everyone. We begged people to get ready for fentanyl. It didn't happen. It's here. People are dying 2 a day in Nevada right now. And this is an interesting place. We've come to a place where losing 2 people a day is just normal because it's better than it was. I mean, I don't know how we got here, but let me tell you the new drug that we have to watch out for, they're called nitazines. Nitazines can have, we're not quite sure, up to 20 times the strength of fentanyl. They are happening in the East Coast. That means they will happen here eventually. We also have xylazine, which is a drug that is kind of a veterinary product. It's being misused. It's got a lot of negative consequences, can cause infection and death. That is being mixed with fentanyl. It's very popular in the East Coast. We do believe that that is actually getting chemically changed. Still an illicit drug, still a drug of abuse. It still causes a lot of problems. We're hoping that that won't be as impactful as we've seen in some of our East Coast states that we're dealing with the mixture of xylazine and fentanyl. But the one that I would really love that we could start working towards would be how do we protect our citizens against nitazines? Because once that settles in, it will probably take over too.
Thank you. Just to follow up relative to that, I'm curious to know if you are participating in national organizations as this new emerging problematic next wave of drug is taking across our country so that we can be better prepared here in Nevada, so that when folks unfortunately start to experience those adverse conditions relative to this very powerful drug, that we are prepared to be able to treat them, and our physicians are aware of what it looks like.
I would like to, John Firestone, for the record, I would like to have that answered by my co-presenter down in Las Vegas, please.
Dr. Smith, for the record, yes, I actually sit on the National American Association for the Treatment of Opioid Dependence Board. I represent the state of Nevada, and we're all executive directors that are from different states. And this is something every 18 months, we have an international conference. So yes, there's a lot of boards. These boards, we are addressing the opioid crisis. Twice a year, we go to Washington, D.C., and we have Hill visits. And we talk to all our legislators there about the opioid crisis. So yes, the president is Dr. Mark Perino, and he stays on the forefront of everything. So yes, we are all involved with this.
Thank you, Dr. Smith. Thank you for your presentation. I believe that we have answered all of our questions, so I want to thank you very much for being here and for addressing this issue. We will move next to our agenda item number 5, presentation on the mental and behavioral health services for incarcerated populations and the implementation of medication-assisted treatment and substance use disorder. Sorry, did I take somebody out of order? Oh, pardon me. Hold that for one moment. My apologies. We're going to stay in the agenda item we were just in and move to our second presentation. Come on up, ladies. Thank you so much. Michelle Berry, Executive Director for the Center of Application of Substance Abuse Technologies here at the University of Nevada, Reno. I apologize. Please, you may begin whenever you're ready.
Thank you. Thank you, Chair Brown-May and members of the committee. My name is Michelle Berry. As Assembly Member Brown-May mentioned, I'm the Executive Director of CASAT, a center within UNR School of Public Health. With me today is my project manager, Morgan Green. We did prepare a presentation, a PowerPoint presentation, but I will not be using it today. So you can review that at your leisure. You've just heard from the Nevada Opioid Treatment Association, and I want to build directly on what they've shared. The number one ask is a number I'd like you to hold on to. Only 37% of Medicaid-covered Nevadans diagnosed with opioid use disorder received a medication prescription within 90 days of that diagnosis. That means 63%, nearly 2 out of 3 people, didn't get one of the most effective treatments that we have available. Set alongside the broader picture, Nevada recorded close to 1,400 overdose deaths in 2024, and our overdose rate runs about 22% above the national average. Fentanyl is now involved in more than half of those deaths. But there's another factor to consider, and that is that 75% of all overdose deaths in Nevada in 2024 were combined with at least one stimulant. And so the death rate from opioids combined with stimulants has risen 260% since 2019. This is no longer just an opioid crisis. This is a polysubstance crisis, and I think that is a direction that we need to be looking towards for response. So I recognize I put a lot of information and statistics in that right now, so thank you for bearing with me. You've heard a lot about the problems that Nevada experiences, and CASAT has been part of Nevada's behavioral health infrastructure, providing solutions since 1993. I want to walk you through what CASAT has been doing specific to the opioid space across 4 areas: training and workforce, getting naloxone into communities, bringing treatment directly to rural Nevada through mobile units, and then helping support the building of the infrastructure through the state opioid response grant. Before I get into that, I do want to recognize some important work that's happened in this building, specifically Chair Brown-May and Senator Titus. Thank you for your leadership on Assembly Bill 394 in the 83rd session. The bill authorized the Board of Regents to require NSHE institutions to adopt emergency response plans for opioid overdoses, ensuring naloxone was accessible to students. To date, we've distributed approximately close to 2,000 units across the UNR campus. Our team has worked with TMCC to establish their distribution protocols. And then we're currently working with Great Basin College to complete their distribution protocols. So again, thank you. So let me tell you a bit about CASAT and what we do. You did receive some materials from what we provided, the CASAT highlights document, and then another document that provides more statistics on what our Nevada Opioid Center of Excellence has provided since its inception in 2024. CASAT's opioid-specific work through the Nevada Opioid Center of Excellence, the mobile treatment units, and our state opioid grant response work is, again, what I'll focus on today. But I do want to let you know that CASAT is much broader. We house one of the most popular minors at UNR in addiction treatment services, with over 800 students enrolled every semester. We additionally offer graduate certificate programs to practicing counselors who want to become more involved in the treatment of substance use disorders. We manage the Nevada Certification Board, which credentials community health workers and peer recovery support specialists. We run several student-focused programs focusing on recovery support and power-based violence. And we work closely with BSEEN to certify substance use disorder provider organizations under NAC 458. We've also been instrumental in getting the Washoe County Sheriff's Office to become the only detention center in Nevada certified as an opioid treatment program. Our certification team has supported multiple providers in expanding their continuum of care, included integrated treatment for pregnant women with OUD. So there is a forward-facing website that looks at certification, and it also serves as Nevada's treatment finder, Behavioral Health NV. And so if you wanted to peruse that, I'll let you take a look at that. If you have any more questions, let me know. And then in workforce, the Fund for Resilient Nevada approached us and asked if we wanted to help support training and technical assistance for all of Nevada in identifying what opioid use disorder is for anyone who has been impacted, for any communities that have been impacted, to provide free continuing education to behavioral health counselors, physicians, anyone that requests it upon demand. So if a community has a request specific to what does an opioid look like, what is opioid use in my community, we're able to meet with them, establish what their training need is, and deploy a training immediately to what their ask is. And so again, that launched in 2024, and to date we've trained over 5,000 individuals across the state. We have 4 opioid coordinators that also provide face-to-face services throughout the state. So they check in with all of the communities, identify what needs they may have. Is it workforce? Is it training? Is it additional naloxone resources? What might they need, and how can we help provide any type of infrastructure or implementation support? There are some additional documents that we provided that do outline the trainings that have been provided, and then the communities that they've been provided to. For naloxone distribution, CASAT has been distributing naloxone to community organizations and first responder organizations since 2018. Since 2018, we've distributed approximately 222,000 units and over 303,000 units of fentanyl test strips and 150,000 xylazine test strips. So I think that that's just something important to consider moving forward, is this finite amount of dollars to continue purchasing naloxone and then deploying that into communities at no cost to the end user, and because dollars are scarce and it may not last forever. So we have also received a 2-year grant to purchase and implement mobile units within rural communities. So we purchased through the Fund for Resilient Nevada 3 mobile units and are collaborating with 3 community partners to move treatment into rural communities and then be mobile. So instead of just a brick and mortar location, the unit has an established schedule, which communities it will go to, and then is available should a client need arise. And so they're providing urine test screens, biopsychosocial, virtual meetings with a counselor or in-person meetings with a counselor, peer recovery support services, community health worker work. The 3 organizations that we're currently contracting with is Roseman University, Vitality Unlimited, and West Care, Nevada. So each of the mobile units are currently operational and serving the communities that they've been designated. I think that one thing to also note is that Nevada's strategic priorities are all well documented. Expand rural and mobile treatment access, invest in opioid treatment programs, scale harm reduction, strengthen data systems, improve cross-system coordination. And CASAT is working within each of those priorities right now, but the work does require sustained commitment to keep going and continue growth. The mobile units are something to further consider expanding and replicating, but replication does require an investment. The workforce training pipeline through NOS is producing measurable practice change, but it requires consistent funding because it's providing these services for free to the individuals requesting. The naloxone saturation network reaches corners of Nevada that no single agency could reach on its own. But again, because dollars are finite, naloxone may not be made available forever. And something along with what Noda was saying, that with reimbursement not meeting what the threshold may be to sustain workforce, that may continue to be a problem with workforce and the appropriate staffing needed to sustain a community. So I think those are all things of note to consider as you're moving forward in the legislative session. And please know that we're grateful for the leadership of this committee and opportunity to be here today. And please lean on us should you have any additional questions or concerns or need additional information. Thank you.
Thank you. Thank you for your presentation. I apologize if I didn't mean to jump over you in the beginning.
Okay.
I was actually really looking forward to seeing you, so thank you. Members, questions? Okay, I have a couple. So really, thank you. At a presentation I received recently, there are some jurisdictions that are formally approving the use of naloxone 10 years after its expiration date. Do we have any research? Have you heard of that? Are we considering knowing that dollars are finite?
Morgan Green for the record. So naloxone, there has been plenty of research since its initiation that naloxone is viable up to 10 years post the production of it. It doesn't go bad. It will just very slowly degrade over that period of time. The only piece is that it is up to the pharmaceutical companies themselves to ask the FDA to continue to expand those expiration date requirements. The only one that has done that up to this point has been Emergent. So Narcan, the brand name, is the only one with a 4-year expiration date that is currently posted. The others are currently either 2 or 3 years, depending on just the different companies that are out there. But all of them, as it's the same formula, are actually viable up to 10 years.
Thank you for that clarification. And then to your comment about this is really a polysubstance crisis and not just an opioid crisis, are you all experiencing or seeing new drugs coming in that we're having to treat people for, and how is that affecting CASAT?
Michelle Berry for the record. So I think that what we're seeing is, what we're trying to do is provide training and technical assistance on what we're seeing emerge from the East Coast traveling west. So like Mr. Firestone had mentioned, the introduction of nitazene, of a hybrid xylazine. And so to prep providers for this potential incoming, but that's really what we're seeing is just the trends that are happening east coming west.
Thank you. I don't see any other questions. Now we will officially close this agenda item. Thank you so much for being here. Okay, we will open agenda item number 5 and move to the presentation on the mental and behavioral health services for incarcerated populations and the implementation of medication-assisted treatment for substance use disorder. We'll welcome up our presenters, Robin Fries, the Director of Substance Use Disorder Program at Department of Corrections, and Francis Oakman, Mental Health Director at NDO. Thank you so much for being here with us today, and you are welcome to begin whenever you're ready.
Hello, I'm Robin Feast, Substance Use Disorder Program Director for Department of Corrections. And this is my
Dr. Francis Oakman, Mental Health Director for Nevada Department of Corrections.
Thank you for the opportunity to share what we are doing within the department. We are going to share about a couple different programs that we have running. We'll start with mental health and behavioral services with Dr. Oakman.
We offer referrals to the substance abuse program, crisis intervention, monthly and bi-monthly mental health checks for offenders in the mental health program. We also assess for suicide, suicidality, and we address mental health concerns, psychosis, sleep disturbances, and other issues through education and developing healthy coping strategies. Behavioral health services provided. We have a behavior modification unit, which provides reintegration process into appropriate housing for offenders who have had trouble adapting to housing outside of segregation. Some of these offenders are experiencing substance abuse issues. We also offer psychoeducational groups. Any challenges or barriers? So a significant challenge involves achieving authentic engagement from individuals who may be reluctant or ambivalent about participating in mental health services.
For our substance use, hi, Robin Feast for the record. For our substance use disorder programs, we currently have 3 programs. We have 2 for our males. One is at Southern Desert Correctional Center. One is at Northern Nevada Correctional Center. Our females have 2 programs within 1 unit, and that's at Florence McClure Women's Correctional Center here in Las Vegas. Each of those programs are in a dorm setting. So if you imagine a big gym, 120 beds, our staff offices are in the back. We do groups. Those staff offices are our group rooms, our storage rooms, our staff offices, our crisis rooms. We are in the unit embedded with them. Each of those units can hold 120 people that are incarcerated. Depending on our population, that's about 3% of the population that we can serve. For our male sites, we tend to always have a waiting list. For our female sites, the reason we created 2 different programs was oftentimes the women will come into custody with either a large chunk of time or a short amount of time. We created a shorter program, 5 months, to try to target those women that come in with a little bit shorter amount of time. When we started our journey with substance use disorders, we began in 2012. We partnered with University of Cincinnati Corrections Institute. They have an assessment tool that will tell you how closely you follow the 8 principles for effective programming in a correctional setting for a correctionals population. We knew we would bomb that first assessment. We could tell that just by our own internal assessments. And that was exciting to us because partnering with UCCI and their assessment gave us a roadmap of how really to show the commitment that we had to following those 8 principles and that we could do things quickly. Normally between your baseline assessment and your follow-up is 1 to 3 years. We had 6 months to show that commitment. We went from low adherence to evidence-based principles in 2012 to in 2013, we hit moderate adherence. We had our follow-up in 2014 where we had achieved high adherence to evidence-based principles. And then our last one was 2017, where we were just a few points shy of very high adherence to evidence-based principles. If you notice to the right of that screen, we exceed the national average and have done so since 2014. In 2022, we have part of our program is funded through Residential Substance Abuse Treatment Fund, RSAP funding through BJA. Their partnership with Advocates for Human Potential came and did their own fidelity assessment to see how closely we're following those evidence-based principles. They also expanded it to include more focus on reintegration and medication provision as individuals in custody transition out of custody. And our scores for substance use treatment for the domains that we have direct influence over exceeded the national average. So that was 2 different entities with 2 different tools, still focused on those 8 principles, showing that we have not only maintained it, but achieved high adherence to the evidence-based principles. We consider that a win for us. It also makes us nationally recognized, which we're very proud of. Because of these assessments and our partnerships, we became a site tour for RSAT, which means Department of Corrections teams from across the United States and territories came to us to learn what we do within corrections for substance use disorder programming. Myself and my team speak nationally at conferences regularly. We have flown to other states to train their teams as well. Our model works, and that's exciting to us, especially where we started from. And so we embody those principles. It's not only something we say we do, our clientele know what those principles are, why they're important, our staff members know it. So one of those principles is dosage of treatment. The way I explain this is, if you do substance abuse treatment in the community, it's very medical model, focus on triggers, cravings, urges, people, places, and things, which is very important. However, when you have a correctional population and you only target the domain of substance abuse, you've actually made them a better criminal because now they're a sober criminal. And people kind of chuckle at that. But the truth of the matter is, when you're dealing with a carceral population, you have to target the criminal thinking aspect of that. We also have to manage that with the substance use treatment. And so that's why the model for a carceral population looks different than what you would expect in the community. And that's not just doing programming in a prison setting or a jail setting. It is also for those community providers who in the community, when people come out of custody and are looking for support and treatment, they need those same 8 principles. They need those same programming standards because their needs that bring them in and out of custody remain different than somebody who's never been touched by the criminal justice system. For our specific programming unit, their items in green are the domains that per research will say when you have a high need in one of those domains, it can increase your likelihood to come back into custody. We want to make sure that we provide programming that hits all of those domains so we can individualize treatment based on the needs of the people that come into our custody. But also what we know is that the pathways that bring women in and out of custody look very different than that of men's. We need to be able to respond to the specific needs of our female population. Those are the domains in pink. So what we use these charts for is to ensure one domain is not oversaturated at the expense of another, and where is gaps in our service that we can increase that. The truth of the matter is our general funds budget for our substance use program is less than $40,000 a year. That excludes salary. I can't run one program on $40,000 a year, let alone 3. And we only have enough staffing capacity and bed space to target 3% of our population of people in custody. There is a huge need for our population that we are not able to provide those services for. So we do make every dollar stretch, and we use information like this to make sure in the amount of influence we have that we are being diversified with the treatment we can offer. When it comes to our medications for opioid use disorder, we began our journey with the department in 2017 using Vivitrol, which most departments will use. Vivitrol is a long-acting injectable for naltrexone. You offer that at the end of somebody's incarceration. You provide them with community providers where they can continue treatment in the community once they release our custody. By 2022, we started talking about expanding those efforts. And what that looked like is our first phase of our MOUD project that we have called ORION, Opioid Recovery Initiative of Nevada, DOC. We partnered with Behavioral Health Group using their physicians through telemed to prescribe long-acting injectables for buprenorphine for our people in custody. Their behavioral health group nurses would come into our facilities monthly to administer the medications. We received our first patient from Washoe County April of 2023. We didn't receive our second patient until December of 2023, so a slow uptick initially. With that, behavioral health group has come into our facilities all the way up until September 30th of last year. At that time, we were able, through the partnership with Chief Cook and Department of Human Services, to hire 4 LPNs that were specific for our MOUD project, 2 program officers, as well as a MOUD coordinator. That allowed us to bring those services in. Our NDOC physicians prescribe the medication, our MOUD LPNs administer the medication, monitor for side effects along with the physician. They also complete support forms, which is through the federal government, some basic information forms that are tied to our funding. And then our program officer twos, the first year they were tasked with screening as many people in custody as we could reach with a drug screening form. We wanted to know real, current, accurate information about the drug use 12 months leading up to custody for the people that we have in custody so that we can know how to best treat them. Over the course of the last year, they have completed well over 10,000 assessments, which is amazing to say in 1 year's time. That report is now being finalized. We should have the data within the next 2 to 4 weeks where we can create a dashboard. It will tell you who in our custody, what's the percentage that would have a mild substance use disorder, a moderate substance use disorder, high substance use disorder. What was the main drug of choice used prior to custody? What was the treatment episodes prior to custody? And we'll be able to use that information to really inform our system of what the next step is for us. Some of the wins that we have experienced is that through the partnership with the Department of Human Services and Chief Cook, we applied for the SAMHSA policy for Academy for Advancing MOUD. We were accepted, and there was 5 states accepted into that academy, a team from NDOC, a team from Human Services, a team from Behavioral Health Group, went to Arizona April of 2025. And our goal was to work on our policies, our forms, and our workflow. We were able to work with policy advisors there and leaders in the MOUD program community to really help us hone those. And that's what we've spent the last year doing. Our goal for the department is to continue providing evidence-based programming in ways that are meaningful to our people that are in our custody. We have probably the same problems majority of people do, not enough staff, not enough funding, but we are creative with the blessings that you guys do give to us. We make it stretch. And through the partnership with Chief Cook and her team, we have really been able to get our MOUD project up off the ground. Our long-term desire is to offer all 3 forms of the FDA medication. We are right now a medication first model, and that's simply because of staffing constraints and financial constraints. We know that behavioral health interventions has to be partnered with MOUD to really see the benefits of that. So while all of our MOUD patients are screened for all the programs we offer in NDOC, there are times that they don't qualify simply for their sit-in structure. So limited staff capacity for the behavioral health interventions. We have high turnover for medical staff at times. So when our LPN positions become vacant, medication administration can't stop. Those duties become absorbed by existing staff who are already overworked. In addition, when I talked about the support A and C forms, those are specific forms that are tied to our funding grant, and they can't not be done. And so when we do have vacancies, other staff members have to step up to get those completed. When it comes with addiction or MOUD in general, there's a stigma. There's a stigma among people incarcerated. There's a stigma among stakeholders, medical professionals, behavioral health intervention and professionals, family members. It's our job to continue to educate in ways that are meaningful to the people receiving it so people can make informed decisions. MOUD is not a magic tool. It is simply a tool. And we should be able to offer a variety of tools to individuals who are in custody to help them set themselves up for success, to break those generational traumas. We're a correctional facility. We have lockdowns. We have emergencies. Again, medication administration cannot stop. We have to work within the facilities to still get those patients the medications that they need. And that can be troublesome sometimes, and we problem solve through it. For our recommendations, it is again our desire to offer programming for all of our MOUD patients. It's our desire to expand our mental health services reach. It is our desire to expand our substance use disorder programming reach beyond 3% for our population that's in custody within the state. To do that, we need staff, we need programming money and funds, we need medication funding. We would like to scale our project. Right now, our MOUD project is such that if you're stabilized on buprenorphine in county jail, we will continue you on that while you're in our custody. We want to be able to expand MOUD to anybody in custody. And so with that takes more staff and more funding. We are proud of the work we have done. The last thing that I'll share as a win is that we were recently recognized by the National Associate of State Alcohol Drug Agency Directors. We were recognized for our MOUD project for being innovative initiative, and that just occurred a couple months ago. And we also had a feasibility study done as part of Senate Bill 35 that was completed by MindCare and submitted to the committee previously for review, and we can get that to you again. So those were a couple of our recent wins. At this time, we'll take questions if you have any.
Thank you. Thank you for the presentation. We'll start with Assemblymember Goulding.
Thank you. Thank you for the presentation. That was a lot of information, so I apologize in advance if you included this information and I just didn't quite catch it. What percentage of the incarcerated population should be receiving MOUD? You said that 3% are receiving treatment. Ideally, what percentage?
We have bed capacity. Hi, Robin Feast for the record. We have capacity for 3%. Our programming bed space is 3%. The TCU drug screen, the 10,000 pieces of data that our screening of 10,000 people, that report will be ready in the next 2 to 4 weeks, and that will directly answer your question with a real number.
So right now, you don't have a sense of how many folks in custody should be receiving treatment?
There's no drug. Oh, sorry. Robin Feast, for the record. The director shares those stats, and I don't have those with me, but we can get those to you. I can tell you that we were not embedded in the intake facilities for a specific drug screening tool. Those questions were part of the general intake tool, and so that's why part of our project with Orion was to ensure that we had a validated tool that would give us that correct information, not only for the history of people incarcerated, but we also will be able to pull it for our current population. So we can get you what the director has reported in previous presentations. Otherwise, we'll get you that report.
Thank you.
Thank you. I appreciate that you would follow up with that detailed report. I think that's really the number that we're trying to get at. How are we addressing the current population and to help them when they come out of incarceration and potentially re-assimilation into society, right? How are we treating while we have folks available who are interested in receiving treatment? And so thank you for the data that you provided today. I think it's a good first step for us as a committee to consider how we'll continue to look at aiding you and the service of the support that you need to better build out programs. So I would look forward to receiving that report. I really want to thank you for being here today with us and presenting this information. Okay, thank you. That wraps up the first part of our policy proposals. Presentations rather. We're gonna move into policy proposals, which is item number 6. We have a number that are listed on our agenda, so we'll take them one at a time. We'll start with the Nevada Mental Health Parity Enforcement, Laura Drucker and Michelle McGuire. And if you will come forward with your presentation. Oh, thank you, you're on Zoom. And you may begin whenever you're ready.
Thank you, Chair Brown-May and members of the committee. My name is Dr. Lori Drucker, and I'm here with my colleague, Dr. Michelle McGuire. We are the co-chairs of the Legislative Committee of the Nevada Psychological Association, and we are grateful for this opportunity to talk with you about mental health parity enforcement. Healthcare accessibility and affordability are top concerns across the country. Although parity laws have been in effect nationally since 2008 and in Nevada since 2009, they have not been enforced. And that matters because the consequences are felt every day by consumers, providers, and entire communities. We hope to see collaborative solutions. Insurance companies have a clear responsibility here to eliminate disparities between medical and behavioral health care coverage and to ensure that consumers receive the benefits that they're paying for. The Division of Insurance has the knowledge and authority to identify where violations are occurring, but enforcement requires adequate staffing and resources. Nevada has a strong bipartisan history of supporting mental health parity, and we encourage that leadership to continue. Effective enforcement of mental health parity requires coordination between regulators, legislators, providers, insurers, and consumers. Only then can parity move from promise to practice and from law to lived reality. I'm going to skip over these first couple slides. This one goes a little bit over the history of NEPIA.
At its core, an insurance company's responsibility is to support the medical needs of its members. Yet in Nevada, unnecessary barriers continue to limit access, especially in mental health. Mental health care is just as essential as physical health care, but is not treated equally. These inequities have real consequences for both providers and patients. I spend a significant amount of time not on patient care, but trying to get paid for services already provided. Despite high community need, I am facing financial instability, not because patients do not need care, but because the reimbursement system is not sustainable. These are systemic issues that directly affect access to care. Lengthy contracting processes delay providers from serving patients. Reimbursement does not reflect the time, training, or complexity of the service provided. Claims are frequently denied or underpaid without clear or consistent justification. Insurance panels may appear sufficient on paper, but many listed providers are either unavailable or lack the needed specialties. At the same time, qualified providers face delays or denials in contracting, leaving patients without real access to care. These challenges are driving providers out of insurance networks and into private pay, reducing options for patients and widening the gap between coverage and actual access.
You have all probably seen some of these reports showing evidence of systemic noncompliance.
Why does this matter? Because these are not abstract policy issues. They directly impact the people we serve every day in Nevada. When access is limited, care doesn't just get delayed. It often doesn't happen at all. That means misdiagnoses, worsening symptoms, and preventable crises. Families are increasingly forced to choose between paying out of pocket or going without care, despite paying for insurance that is supposed to cover these services. And the result is exactly what we're seeing. Nevada continues to rank near the bottom nationally, with high rates of suicide, substance use, and untreated mental illness. Research from Mental Health America indicates 50% of adults in Nevada who need treatment do not receive it. Nevada is ranked 51st in access to care. We're last, and that should not be acceptable to any of us. How do we feel about that? And more important, what are we willing to do to change it?
AB 181 required reporting of NQTL data to verify MIPIA compliance. Reports published by the Division of Insurance since 2022 show noncompliance across all metrics. The transparency requirements of AB 207 allowed the Nevada Independent to review these reports and which confirm that mental health parity violations are not isolated incidents, but part of a broader pattern affecting multiple insurers across Nevada. When 16 carriers are out of compliance, the issue is no longer about individual behavior, it's a systemic failure. We need to see accountability to the laws through stronger enforcement.
If we are serious about improving mental health outcomes in Nevada, the path forward is clear. It comes down to three key areas: strengthening enforcement, improving access to care, and supporting providers. First, we must strengthen enforcement of existing laws. These laws are already in place, but without consistent oversight, accountability, and consequences, they don't function as intended.
Enforcement means ensuring that insurance practices like contracting, prior authorization, and claim denials are actually aligned with parity requirements in real-world application. Second, we need to improve access to care. That means addressing not just whether services are covered, but whether patients can realistically obtain them. It means reducing delays, ensuring adequate networks, and removing barriers that prevent timely diagnosis and treatment. And third, we must support providers. If we want clinicians to stay in insurance networks and continue serving insured patients, reimbursement must be sustainable, administrative burdens must be reasonable, and payment must be timely. Without it, we will continue to lose providers from the system. These steps are not independent, they are interconnected. When we strengthen enforcement, we improve access. When we support providers, we expand capacity. And when we do both, we move closer to a system where parity is not just promised, but delivered.
These slides show examples of some interventions that you may want to take a look at. In the interest of time, I'm going to go through them quickly and summarize for you. Putting teeth into enforcement shifts the responsibility to preventing problems, not just acting after them. When we enforce parity only after harm has occurred, we've already failed our patients. Nevada can follow the lead that other states and policy experts are recommending. Tools like targeted market conduct examinations, proactive audits, and data reporting requirements allow regulators to identify coverage gaps and require clear remedies. Enforcement must include consequences. When insurers face corrective action plans, financial penalties, or mandated operational changes, they have a clear incentive to fix systemic issues rather than make surface level adjustments. This is what transforms parity from a compliance exercise into real change in how care is being delivered. Equally important, strong enforcement drives system-wide improvement. It encourages insurers to redesign their processes, how they build their networks, how they set reimbursement rates, and how they apply utilization management tools so that parity becomes embedded in the structure of care delivery, not just in policy documents. Enforcement teeth matter because without them, parity laws exist on paper, while disparities persist in practice. For patients and families, those barriers don't look like a violation of care, they just look like difficulty accessing care.
This isn't just about policy, it's about people. When the system fails, patients don't get care, providers can't stay in practice, and the gap continues to widen. That is something we have the power to change. Parity was meant to ensure access. Until we enforce it, the promise remains unfulfilled.
Thank you for your time and listening to our presentation. We are more than happy to answer any questions or go back over some of the enforcement slides. I also encourage you to look at some of the links we have provided. There is a lot of information available nationally.
Thank you for your presentation. We appreciate you being here and the material that you've provided. We do not have questions at this time, and we look forward to following up with you. So thank you so much for being here this morning.
Thank you.
Okay, that leads us to the next policy proposal presentation on our agenda, financial support to expanded Nevada Peer Support Network services. Charlie Tabano, Nevada Peer Support Network. Thank you so much for being here. You may begin whenever you're ready.
Hi, my name is Charlie Tabano, and I am currently the operations manager of the Nevada Peer Support Network. Next to me is Derek Reed, the president of the Nevada Peer Support Network and a battalion chief for Truckee Meadows Fire. I came to the Peer Support Network as a retired paramedic and first responder with over 40 years of experience from fire to EMS, and unfortunately was able to conclude my career in that business working as a death investigator for the Washoe County Medical Examiner's Office. I came to the Peer Support Network seeking help from an accumulation of trauma that I felt my brain and my body absorbed over all those years. Met Derek. We actually worked together a long time ago. And after doing being helped pretty strongly by the therapists that worked there and just met a bunch of really great people who were also first responders, retired. I decided this is my passion and this is what I'm going to do until I can go on no further. So I also like to introduce again Derek Reed, who can speak with you a little bit about his background.
Good morning. For the record, Derek Reed, President and founder of Nevada Peer Support Network. I'm also Battalion Chief with Truckee Meadows Fire. I have 33 years in EMS and fire. The Nevada Peer Support Network, which was formerly Northern Nevada Peer Support, which is now Nevada Peer Support Network. In 2019, I began a program with Truckee Meadows Fire, a peer support program where peers, firefighters, line firefighters, were trained on how to support each other. In 2 weeks after we put a phone list out for those that could reach out to for help that has had that training and has confidentiality in mind, one of our, sorry, this is the hardest part. So 2 weeks after we put our phone number list out, we lost one of our own. So in our post-vention efforts to support our department, the family, and each other, we didn't know who to call. We didn't know who that we could reach out to that can come and support us. Yes, we had our own peer support team, but they were ineffective in supporting each other because they were also affected deeply. Fire service and law enforcement and all first response culture is very family oriented. We depend on each other in the worst of times across the board, and we didn't have the capacity to do that. So even though we were trained, we just didn't have the capacity. So we didn't know who to reach out to. We eventually found resources that would help us in the short term. We didn't know what the long term looked like. And then once we started learning about resources, we figured out what that 1 month, the short term, and then all the way out to 1 year when the anniversary date comes around. During that time frame, this was in June. A month later, Henderson Fire lost one of their own for the same reason. It was a firefighter that took his own life. Having obviously a lot of empathy to that, I reached out to that department, and he echoed the same words that I said when we were trying to work through our postvention, is I don't even know who to call. He said the same words. And it was at that moment that I realized that we need to figure out how to come out of our silos and figure out how to support one another statewide, even outside of our state. We just needed to know, who do we need to call when something bad happens? First responders, when bad things happen, people call first responders. When bad things happen to first responders, who do we call? We didn't know. There was nothing there for us that we knew. Law enforcement, hospital, they're silos. Firefighters are very different than law enforcement. However, we see the same things. We go to the same calls. We have our own support mechanisms, but there's silos. And our attempt with the Nevada Peer Support Network, and I might say that it was successful, that we've learned how to lower those boundaries, share resources, collaborate, and figure out when something bad happens, how to support one another. The Nevada's Peer Support Network model works. I think we're going to be going into our 7th year. We've had things happen locally with law enforcement where law enforcement has lowered their barriers to allow us to come in as firefighters to support them, and we've done the same for them. We've slowly are changing the culture for that. our mission is to collaborate, to share resources, to figure out how and what are the best resources. Culturally competent resources, which is extremely important. We have stories of firefighters and law enforcement reaching out to other resources such as clinicians and chaplains that weren't culturally competent. That doesn't go well. They don't understand, or they become very frustrated quickly because they don't understand the culture, they don't understand the type of calls we go on, and some of the calls that were shared, actually, I can count, I'd have to use both hands to say that we've had first responders tell stories that has made clinicians cry. At that point in time, if you can put yourselves in their shoes, the thought is, wow, I must be really messed up. I just made this person that's supposed to help me cry. So that becomes very difficult in learning what those resources are that are good for a warrior servant. That warrior servant you may have one shot at. So our job at the Nevada Peer Support Network is to figure out and vet those resources that we know that are going to work the first time. We need to know they're available. It's different than Gen Pop. When a first responder cries out for help, it's been a while. The wheels are coming off. It's not, I feel kind of, it's serious. So that's our mission, and that's so they can live the best lives possible for them, their families. Our stakeholders are basically all the first responders, from the first responder to the last responder. We're talking about the person that takes the 911 call all the way to the person that's at the coroner's office. And it sounds like a broad brush. Most of those personnel are in the middle, in the law enforcement, fire, hospital, EMS. But we don't exclude. Our core value that we hold close to us is inclusivity. And we try to serve those that serve, which is a challenge. It's about changing culture. It's about turning an aircraft carrier on a dime. And this is what we are doing. So, as far as the first responders, how are we different? I think the statistics that are out there show how we're different. Our numbers are elevated in basically all categories that you see with the general population. The 1 in 4 people suffer from some form of mental illness any given year. There's a single event occurrence that could happen that can throw a first responder into a tailspin or deal with some kind of issue that requires further assistance. 85% of first responders have experienced symptoms related to a mental health condition. Now, I look at that number and I say, and I think I can speak to this based on my years of service, 85%, I would think that 100% of first responders are affected in some way, because if they weren't, based on what they see, then they're not human. And I've taught at the college level for EMTs, paramedics, and firefighters, and I can tell you in that curriculum there's nothing about how to care for yourself, how to keep yourself resilient, how to maintain your family. I apologize. A lot of this I've seen firsthand. 30% of first responders develop behavioral health illness, including but not limited to depression, PTSD, compared to 20% of the general population. I've even seen 6. I'm not surprised it's 20. 7 in 10 responders will say they are more likely to speak to professional counseling if the leader in their organization spoke openly about their own experience. This is where peer support comes in. I know people outside of the state, in the state, that would have sought help earlier if somebody that was standing next to them doing the same job normalized that conversation of mental health. That is where the peer support system works. Yes, there's professional help out there, but that door does not open unless somebody comes alongside and says, hey, yeah, I understand what you're going through because I'm doing what you're doing. And it's really important. You know, these things that are on the next slide, the anxiety, the depression, the post-traumatic disorder, the substance abuse, that's just 4 things that has a ripple effect into so many other things. It leaks into the family, it can leak into the financial aspect, moral injury, compassion fatigue, disability, burnout, lack of engagement. It is really difficult to, this is just the beginning. It leads into what is a huge problem in the fire service and law enforcement, and that's suicide. Suicide is difficult to discern whether, a lot of times, you know, suicide, it's not always clear cut, and like a drinking disorder, somebody that drinks themselves to the point to where they become incapacitated and end-of-life procedures happen. Again, I have also seen this. Line of duty deaths, it's a mandated report. If somebody dies in line of duty death, that number is a hard number. Suicide, if they can validate it and it's a first responder, then it becomes a hard number. The line of duty deaths, well, let's just say this the other way. Suicide in first response culture has exceeded line of duty deaths ever since they started paying attention to it back probably about 2017, 2018. That number, when you look at suicides exceeding line of duty deaths, you can kind of come to the conclusion that that first responder has become more dangerous to himself than his high-risk job that he occupies. There's a reason for that. The trauma exposure, a normal day at the office, you're going to see something. And again, these are normal people doing extraordinary jobs. What is their support mechanism? There really hasn't been. You can go see a counselor. There's a chaplain. Read a book. We've made it our business to know, okay, what does it take to keep a first responder standing and doing a career job and doing a good job serving the public? And we've done that. Yeah.
All right. For the record, this is Charlie Tabano again. So I just happened to prepare this PowerPoint, and I asked Google to tell me about what mental health crisis interventions are available to the public in the state of Nevada. And this popped up, and I saw 3 spots down, the Nevada Peer Support Network, which I thought was interesting, but that was the only one that was there. And as Derek said, we do have lots of resources from each individual department, but the stories that we get all the time, and I'll without breaching confidentiality, I get a phone call from a sheriff's deputy who lives outside of Washoe County in the rurals, and he said, "Hi, I'm wondering if you can help me. I'm up for a promotion. I was involved in a shooting a couple months ago. I'm having a really hard time sleeping." So we do a phone triage thing, and he stops me. He says, "Charlie, I'm not going to eat my gun. I got 2 kids to put through college. I just want to be able to get a good night's sleep so I can get back on track. I'm up for this promotion. I don't want anybody to know. We have our own peer support group, but can you help us out?" Within a few hours, one of our vetted therapists contacted him and was able to see him the next day. He calls me. I gave him my cell phone about a month later and said, "Thank you." And I got the job. So these are kind of just interesting stories, and we've got hundreds of them because this happens every day. Yesterday I met with Derek to kind of prepare for this discussion today that we're having with you, and I received 2 phone calls of a similar matter. A death of an 18-year-old where a fire crew responded, worked on the person. Some people knew this kid because it was a small community. We spent a lot of time working in the rural Nevada areas. These places do not have any peer support. They don't have vetted therapists and things like that. Last Sunday, I'm sitting home watching hockey. I get a phone call from a distraught fire chief from a volunteer fire department in a place I hadn't heard about in the Smoky Valley. And while I'm on the phone with her, I'm looking at my phone to see where the Smoky Valley is, and it's just a little bit, it's closest to Tonopah, apparently. They got a call in the morning for a rollover accident. The volunteer ambulance showed up. Husband and wife are both EMTs on the ambulance, and they find their 20-year-old son killed in the rollover accident. We don't know what to do. Highway Patrol gave us your number and said, call you, and maybe you can help us out. So 2 days later, we put a team together of our trained critical incident stress management folks, and they drove 4 hours down there, spent the afternoon there, and they came back that night. And we're very appreciated. So these are the types of things that we're doing without any support financially. So let's go into the peer support network, exactly who we are, what we do. We have 4 things that we do. We have a resiliency center that we rent. We have a lot of education programs, critical incident stress management, network response. We'll go out to calls and respond to incidents when needed. And our incident support team. We have a nice little place. Thank God the Ribeiro company gives us 50% off on the rent. And within that area, we have a couple of therapists that work their practice out of that. They don't work for us, but they're vetted, and one of them was a paramedic for 24 years before becoming a therapist, so she kind of gets the issues that we're seeing. There's AA for first responders twice a week, which is very popular. We were able to receive a little grant from NV Energy, so we furnished a sensory treatment room with red lights and things like that, red light therapies that the therapists use all the time. It's a really nice place. But most importantly, in the front room, there's a huge living room area that can hold about 15 people, and we do our diffusings there. When there's a bad call, the local EMS fire respond to a horrendous call. They get together. We can do diffusings and debriefings there away from their facilities, so the media doesn't see all these police cars or ambulances out front, and it really works very well for them. We do a lot of training for folks. The more we can get people educated in peer support and what critical incident stress management, how it's supposed to go, because a lot of those have not gone well because the people aren't trained to run them. We have a huge demand for classes. We had one last month. We sold out at 40 students right away from everywhere from the Fallon Naval Air Station firefighters to City of Reno firefighters and paramedics and law enforcement. And we had some dispatchers in there. And we did a 2-day class on peer support and critical incident stress management. Retired people are at risk also. I felt that. I experienced this personally. My dad was a sheriff's officer who retired as a lieutenant in New Jersey and never enjoyed his retirement. We lost him to alcoholism, and a lot of it had to do with the fact that when you lose, and I remember him telling me how hard it was to hand that badge and his gun over to the people in the personnel department when he left, and that was tough. That was very tough for him. And we realized that, and there's a lot of studies showing how retirees, how they can circle the drain when they lose their identity, basically, and their purpose in life. We try to address that. We started a incident support team. We purchased an ambulance. We had a couple of vehicles donated to us. We have 30 retirees now with almost 900 years of experience between us, and this has been a great transition for a lot of us folks to feel good about what we're doing once again. We respond to fires, law enforcement incidents that are long-term. We've been to quite a few wildfires and structure fires. At those fires, we provide heated shelter, air-conditioned shelter in the summertime, healthy snacks, beverages, and basically train peer support people, because a lot of these scenes we go to, people are stressed out. When there's an officer shooting that's involved SWAT, when those guys come back in, they're pretty well amped, and we like to calm them down, and we know kind of how to work with those folks, so we give them some direct assistance right there. We are providing vital services to a lot of different departments in our area. We work very well with the South, and as a member of the Purple Ribbon Committee, which was established by the Nevada Legislature, I can tell you I have a statement from them, and I'd like to read that to you if I can real quickly. Dr. Tenney, if anyone knows him, he's the wellness director for Las Vegas Metro Police. And Dr. Tenney summarized this for us when I asked him to tell me what you would like for this committee to hear today from us. And we already heard many people talk about the lack of how the mental health infrastructure really disproportionately affects first responders. We're going on these calls of these mental health emergencies. We're going on these drug overdoses. We're seeing the bodies and all that. And the civilians are struggling with the access to care, but first responders are absorbing all this traumatic exposure at a really high rate than the general population. You know, the state funds their weapons, vehicles, and tactical training at all full cost. Mental health infrastructure kind of gets treated as an option. That asymmetry is a policy of choice and has its consequences. The cost of inaction is a Nevada taxpayer problem. Untreated trauma in first responders doesn't disappear. It converts into disability retirements, early separations, use of forced litigation, workman's comp claims that Nevada agencies and Nevada taxpayers have to absorb. Peer support and early intervention programs have documented return on investment that far exceeds their cost. Prevention is dramatically cheaper than the downstream liability. We have this structure in Nevada, but it lacks the funding architecture. He further ends this by saying the Nevada Peer Support Network already exists. This is not an ask to build something new from scratch. The ask is for a stable, codified state funding mechanism to sustain and scale what trained professionals have already built. Peer states, including Colorado and others, have passed legislation, created dedicated first responder mental health funding streams to these nonprofits. Nevada is positioned to follow a proven model and no need to pioneer an untested one. So I'm going to finish with my comments here by simply talking about the things that we need funding for. We receive no governmental funding at this point. All of our money comes from grants and donations that we have to seek, and that's what I do most of my day. We have no paid employees at all, although I am the highest paid volunteer, as Derek always says. Our budget is only $86,000 a year for all of our programs, and half of that, a lot of it goes for just insurance purposes and rent for our buildings, insurance on the vehicles also. We really need some help with grant writing. We need basic funding, and from the state would be great, especially to help these rural agencies. I get these calls all the time, and it really stresses us out to reach out to all these folks.
For the record, Derek Reed. I wanted to, one of the slides had the AA. I wanted to just give you some background on that program. We started that pretty close in the inception of the Nevada Peer Support Network. It took 3 years for people to start coming. Initially we had 1, 2, maybe 3 sometimes, and I said don't give up, because we knew that there was a problem with alcohol within first response. That's the way a lot of people cope unhealthily with the trauma that they use. So I said, don't give up. And our secretary for that AA program says, I'm going to keep coming every week. 3 years later, those rooms are packed. There's anywhere from, I'll conservatively say 5 to 15, usually more on the upper end of that. It took that long for that program to be trusted, which goes back to, one, it's a closed group, even though AA is not supposed to be, but here's the problem if it's not. A law enforcement officer cannot go into an AA program in any city that he works in and show up. And we've had testimonies stating that they'll walk in, see somebody that they arrested for maybe the same thing, and they have to walk out. So we've created the safe space for them. The other thing, what is our goal? Our goal is to increase capacity and expansion to be able to have these resources that are all volunteer right now throughout the state. I'm in frequent contact with the City of Las Vegas firefighters, and we talk about having a chapter down there and making sure that we are talking back and forth and sharing resources as it was intended to do. I don't have anything else. Does the board have any questions? We'd be happy to answer them.
Thank you. Thank you for your presentation. First, I want to say thank you both for being here, and thank you for your vulnerability. My 23-year-old is a first responder. He's a police officer in Raleigh, North Carolina. And the stories he calls me with as a 23-year-old, I can't imagine him not having a level of support as he navigates, first of all, being 23 and life experience, and then raising a family. So doing that for an entire career, I can absolutely understand the significant emotional impacts that it has on you as you care for our community. I also can hear how a first responder seeking treatment in a public setting could not do that in an effective manner given the community that we're interacting with, right? So oftentimes we would have to leave that immediate community to seek help somewhere else where you can have a level of anonymity. So know that I hear what you're saying, and I appreciate that you're here and sharing these stories. While the ask is a fiscal ask and we are not a fiscal committee, I appreciate learning about this peer support network for this committee, who is a policy committee, as we continue to address mental health supports for our greater population. With that, members, Senator Titus.
Well, thank you, Madam Chair. And first a comment and then an actual question. So I want to thank you both also, as our chair has just said, but very much so. And I have lived this volunteerism of yours, Mr. Tabano. Many of you, you may not know this, but Mr. Tabano called on me 30 years ago in my very rural little setting in Smith Valley, and I had no resuscitation equipment for pediatrics. And he showed up and gave me a complete pediatric resuscitation kit that we couldn't afford, and he just brought that to me. So his volunteerism has been through decades of service to our great state. My question is this, and again, as our chair just stated, we're a policy committee, and so certainly the policy, I don't think there's a member of this committee that doesn't support the policy, and thank you for your work. But hopefully you have looked at I sit on the money committees, and hopefully you've looked at a budget and what it really does look like and what the numbers would be, and you're somewhere going to bring that forward. We can support the policy, but again, the ask is really about the funding, and we'll need to see, what are your plans, what's your budget, how would you expand with X number? So hopefully that's formed somewhere, and we'll be coming forward at another date to the appropriate committee, the money committees.
This is Charlie Tabano, for the record. Yeah, thank you for that. We actually have a grant writer who works at the University of Nevada, Reno, who offered to do a pro bono grant for us, and gave us a whole list of things that we needed, and we have actually put that together already. So when we do come to you, and if you can help us work our way through that system, that would be great. I mean, I was a pretty good paramedic, but I'm not good at this political maneuvering aspect to try to find the right spot for where we need to be sitting, and I think Derek could probably say the same thing. And, we any help that we can get or guidance would really be appreciated. We know we're necessary.
Thank you. Next, we have a statement, I believe, from Assemblymember Nadeem.
Thank you so much, Madam Chair. Thank you so much for sharing your experiences with us, for sharing our beliefs, what you are doing. You're working so hard for the community, and I just want to assure you, I want to say that on behalf of all of us, that we are highly grateful for your services. You are saving us. You are working hard for all of Nevadans, and we are there. I want to assure you that we are there for you, and we would love to do whatever is in our capacity. Thank you so much.
Thank you. I do have one question. Just as we continue to consider where do we develop support, is there a particular state department that you work with that you would see a peer support network line item potentially in? What state agency would you consider would be the best fit?
Derek Reed for the record. Public safety, I think, is the appropriate location for that. You know, it's difficult not to have that revenue stream, and donations and contributions have been helpful, and it's been keeping us going. But in order to really have an idea of that budget, you know, inflow and outflow is difficult to predict. If that makes sense. So to answer your question, public safety.
Thank you. I appreciate that. Again, I will thank you both for being here. We appreciate the presentation. Thank you for your time. That leads us to the next presentation. We are at 11:43. We're probably going to do this one more, and then we will take a quick break for lunch, and then we will come back. So we'll go into item C on our agenda, deployment of seizure safety training in schools, with Monica Lopez Morales, the founder. I don't see Monica. Oh, is she on Zoom?
We have her here in the south, but she says that she thought she was going at 1, so they're waiting for presenters. So you can skip this one, come back, or up to you, Chair.
Great. Okay, thank you. Then we'll go ahead and skip this for now. That'll move us to item number D, new statutory definition for pediatric specialty care, representatives from neurorestorative. Thank you for being here. Feel free to take your time and get situated. You may begin whenever you're ready.
Good morning, Chair Brown May and Vice Chair Doñate and members of the committee. Francisco Morales here for the record, representing neurorestorative. We've got a quick presentation. I know that we're going to be presenting between you and lunch, so we'll make it quick. But we do want to show just a quick video that I know we emailed out, if possible. It's only 60 seconds, but I think it's going to capture the services that we provide a lot much better than a 10-minute presentation. So I think if we could play it, that would be great.
Thank you. Go ahead.
About 3.5 years ago, Wrecker got critically sick.
Caroline was born with significant chromosomal disorders. She needed 24-hour care.
Mallory's challenges came at birth. She was a preemie. I would have never thought in a million years that my son would get sick and I would have to bring him into a facility like Neurorestorative for Kids, but they're wonderful. It wasn't until I got back and I saw how happy she was. She had new television shows she was watching and the friends in the pod that she made, you know, games that she played, and I realized this is actually good for her.
Everyone here is kind, thoughtful, respectful, loving. It's a second home. We've made this a very pediatric and child-friendly environment. So for the hospital bed and some of the equipment, it would just look like any other family or home.
We have the time and the resources to be able to wrap our arms around the entire family, and we can help guide you, and you're never alone anymore.
Quick video. Joining me today is Lindsay Winger, who is the VP of Operations for Neurorestorative for Kids, and Dr. Rolls, who is the Medical Director for Neurorestorative for Kids, and also We don't have enough space up here for 4, but we do have Daniel Mathis joining us today, who is the CEO of Silver State Pediatrics, who is the other provider that provides these services here in Southern Nevada. So I'll turn it over to Ms. Winger.
Good morning, Chair and Chair members. My name is Lindsay Winger. For the past 14 years, I've served in skilled nursing to support overall operations as an RN and also clinical compliance. In Nevada, we serve 59 peds in Las Vegas and 24 in Reno, primarily admitting from the PICU, NICU, and then also providing local families that needed respite when they need someone to care for their loved ones so they can have a little bit of rest. Our local families really rely on our services, and we provide unique services as far as physical therapy, occupational therapy. We also provide a lot of social support for those individuals that have brain injuries, spinal cord injuries, as well as you saw, birth-related injuries and complications. Our goal is always at the end to hopefully transition to home. But while they need our services, it's important that they have a home-like environment where they have nursing and CNAs and social services, as well as activities and outings to provide care during that transition period, where we can provide education and, like I said, ultimately get them home. Now you'll hear from Dr. Rolls on how the care we provide is very unique in our industry.
Good morning, Chair and some members. I'm Dr. Sean Rolls. I'm born and bred here in Nevada. I actually went to UNLV as an undergrad, went to UNR for medical school, and then did my residency here in Las Vegas, and have now almost accomplished 20 years in pediatrics. Here in part of neurorestorative, we have very specialized pediatric care. It's much different than you would see in traditional skilled nursing facilities. We take care of very small children, all the way from a couple of months of age. Sometimes they're born premature, so by the time that we get them post-gestationally, they may be very small, all the way from a couple of pounds all the way up until the age of 21. They may have very minimal needs, from very just trouble feeding all the way to very, very complicated tracheostomy dependent, ventilator dependent neurocognitive disabilities, severe seizure disorders, severe neurocognitive problems, traumatic brain injuries, spinal disorders. Many of them have genetic disorders that are very complicated. Some of them have been abused. Many of them have significant complications that prevent them from being cared for at home. Usually when I have residents training with me at the facility, I usually kind of group them into 3 kind of broad categories of the reasons that they're at the facility. Part of them are there for short-term. Usually that's because they need some short-term care. Usually they may have a complicated infection that may not need to be treated at the hospital, but can't be treated at home. Maybe they have a chronic osteomyelitis that needs multiple antibiotics that can't necessarily be done at home. Or, for example, recently I had a kid who unfortunately had a severe stroke, and he needed some acute rehab. And so therefore he was at our facility for a couple of months to get that acute rehabilitation, to really get him into a better state for him to be able to continue for that rehabilitation at home. And so we may have them for 2 or 3 months to kind of get them into a transitional period from the hospital back into home. Or sometimes we may have some cares that may have a complicated case where the parents want to be able to take care of them at home, but the hospital isn't able to do that, the education. And so they'll transition to us so we can better do the education and then get them to home. Then we have a kind of a second subgroup, basically, where they just have a bad social situation at home. That might be, unfortunately, a case of abuse where DFS has basically transitioned them into our care. They may have a complicated case where our foster family isn't able to manage them, or basically Child Haven can't care for them because they have a G-tube or a seizure disorder, so they can't care for them there. So they're managed at our facility. So will care for them. And some of those kids, unfortunately, they've been with us for years. I have one kid that I've actually taken care of off and on for over 18 years now. Since I was a resident, I've basically taken care of him since I remember he was at the hospital when he was a small baby. And now he's going to turn 18 in a couple of months or so. I've taken care of him almost that entire time, one way or another. And so we provide a continuity of care for many of these kids when unfortunately there isn't a strong family or social situation for them. And then there's a third group of them who have just such severe and chronic situation that unfortunately there's no way that any family, even if they had 24/7 care, could be able to take care of them at home because they have such severe metabolic disorders or seizure disorders or respiratory needs that they just could not be managed at home. We have 24/7 respiratory care. We have therapists who are there to provide care for them. We have nutritional care for them. We have doctors on care. I'm of course there, available on phone and on call all the time to be able to manage for them. There's no way possible for them to be managed at home. And it's important that we separate ourselves from the adult skilled nursing facilities because of the significant differences in population. A lot of these kids have significant developmental differences, aside from adults. And so especially, I've had multiple discussions with some of the regulators who come in and they try to use the adult sort of regulations on pediatrics, not understanding there's a big difference, when you're trying to say that a little baby should be getting a free water. And I try to tell them, if you give free water to a little baby, that could cause seizures because you're going to cause a dilutional effect. And they don't quite understand the different physiology of a little baby compared to an adult, or trying to tell them that a stroller with a seatbelt is actually a safety precaution and not a restraint. And so having a separate set of guidelines for children is super important compared to a regular skilled nursing facility is very important, and especially nowadays as you look into pediatrics, there's continuing changes in pediatrics because chronic care is becoming more and more of an important issue. As medicine continues to advance, then more and more of the focus goes on to chronic care because immunizations continue to advance, which is a decreased amount of infections, and medicine continues to advance. So asthma and sickle cell disease and a lot of other things that used to be a death sentence now has come to the point where these used to be life-ending diseases now have turned more into a chronic care. And so more and more of these illnesses are now turning into a chronic care. Trisomy 13, trisomy 18, trisomy 21 even, which is euphemistically known as Down syndrome. Now these kids are living longer and longer and more productive lives, but it also means that they have more chronic care issues. And so things that, we're learning to continue to make their lives more and more progressively productive, which also means that we need to learn how to make their lives more productive. And that's where our care comes into hand.
Thank you, Dr. Rolls. And so what we're proposing with this amendment is, first, I want to clarify that we are not adding a new service. We already are doing this. So we already are embedded into the state's Medicaid manual, and we are a licensed skilled nursing facility. So just to give you a little bit of context, a little background, prior to 2015 or so, Nevada didn't have these services. When you had a medically complex child that required these services, oftentimes they had to be relocated to California, to Utah, or to some neighboring states. And so it was a crisis, and a huge. We're very grateful to state Medicaid that they made the administrative change within the manual to cover these services and bring about these services for pediatrics. However, it was never codified into statute. So right now, the only definition that we have in state statute in Chapter 449 is for a skilled nursing facility as a whole, but we don't have a definition for these services for these children. And all that we're looking to do is just sort of bring over that definition, which already exists in the Medicaid manual, put it into state statute, so that we can have these conversations about how to treat these children in a more targeted and intentional fashion. Our intent is that this proposal is going to be budget neutral. It's not going to cost anything. We want to make sure that we're not creating additional work for our state Medicaid. So we're not creating a new provider type. We're not trying to reprogram their systems, merely just to bring awareness to this issue, put in that definition to state statute, and in the future have a more robust conversation about what's included in that definition, how to better serve these children. But for now, it's just giving these children a voice in state statute and importing that definition so that we can have a place for them and a place to have the discussion. But again, no, we wanted to be budget neutral, wanted to make it easy, and we want to make it very simple to give these children a voice. I'd like to turn it now over to Mr. Mathis, who is also here with Silver State Pediatrics. He's a CEO. And just to give some awareness, there's only 2 providers that do this in the entire state of Nevada. We've got Neuro Restorative has 2 facilities in Las Vegas, and we've got 1 facility in Reno, and Silver State Pediatrics has 1 location in Las Vegas. So really, it's only 4 locations statewide. So it's a relatively new area. It's a small market, but nevertheless, it's a very, very important market for the children that we serve. So I'll turn it over to Mr. Mathis now.
Hi, my name is Daniel Mathis, the CEO for Pure Care Living. We do own and operate a 36-bed pediatric skilled nursing facility here in Las Vegas. And I want to agree with the comments that the neuro restorative team has made. We do need some separation and to help identify, what we do as providers. And this, I feel like, would be very supportive. So I do support the effort. Thank you.
Thank you. Does that conclude your presentation?
Yes, Chair, it does. Thank you.
Thank you very much. Members, questions? Senator Titus.
Thank you, Madam Chair, and thank you for being here in the presentation and sharing the stories and the desperation of families at times. I served as medical director for our long-term care unit at Southline Medical Center literally for decades. We didn't separate out that it was a senior care or mental health care nor pediatric care, but I had in that facility, I took care of kids, folks less than 21, and certainly many older, some with mental health issues, some with just physical disabilities. So I'm wondering if this type of addition would change the licensure type and the payment type, and would it help you with barriers for reimbursement?
Thank you for the question, Senator Titus. Francisco Morales for the record. Our intent is not to change the licensure type, the payment type, because we want to make it easy. We don't want to again create more work for state Medicaid. We want to keep the status quo, what's happening now, what's already been done based on the additions to the Medicaid manual. I think in the future we should have those conversations about the age, about the scope, and other things that are involved. But I know that we're facing a very tough financial climate in 2027. So our goal is to keep the status quo, bring in the definition into state statute, and have those conversations. But for now, we just want to be somewhere in statute that we can point to and say, this is what's covered, this is who's covered, and then have those conversations in the future.
Quick follow-up, if I might. And so do you have examples of other states that have teased this out in a different definition in statute?
Francisco Morales for the record. Senator Titus, I think one key example is Florida. Florida has created their own definition for pediatric skilled nursing facilities specifically. But again, we're part of the same cohort of skilled nursing facilities. We are going to continue to be licensed as one. We're going to continue to be participants of the skilled nursing facility provider tax program. We have heard some feedback from other members about, why only until the age of 21. Perhaps we need to look at that and see if there's ways to make that better and change that age. But again, we don't want to change anything that's going to expand the services at this time because we know we're facing a tough financial climate in 2027.
Thank you, and thank you, Madam Chair.
Thank you. Next, we have Assemblymember Nadeem.
Thank you, Madam Chair. Thank you for the presentation. My question is regarding the facilities. As you mentioned that we have 4 in Nevada. And can you, do you have a data by any chance saying that how many children, how many pediatric patients are there in those facilities? And moving forward, what is the need in coming days?
For the record, Lindsay Winger. Currently, we have 78 of our 83 or 84 beds with pediatrics in them. And as far as the need, I believe it's going to continue to go up, especially with the new pediatric hospital that's being built in our state. So we are going to need places for those pediatrics and the families to be supported to discharge home. And so we're seeing the population grow, and with the new hospital, there will be a continued need. And currently 85% of our pediatrics are Medicaid funded.
Thank you. Next question we have from Assemblymember Goulding.
Thank you. I just like a little bit of clarification on what the benefits and advantage are from moving this definition into statute. Can you clarify what you're hoping to achieve by doing that?
Sure. Thank you for the question, Assemblymember Golding, Francisco Morales. For the record, a couple of things. One is just ensure that folks know that we are a skilled licensed facility. We participate in the skilled nursing facility tax program. We're going to continue to do that. The other thing too is right now, we only exist as a matter of policy in the Medicaid manual, not as a matter of law. And I think that in the future, we would like to explore ways or we would like to look at the definition that currently exists with this body to see if it's the best definition that suits children and have that conversation. And so I think for us, it's important that these kids and these services are in statute as we continue to have, as we continue to face a very tough Medicaid environment. Under HR 1, skilled nursing facilities, the cuts to skilled nursing facility provider tax programs is exempted. So, you know, we're not going to suffer from those cuts as a skilled nursing facility. But I think it's important to have us in statute to make sure that we are a skilled nursing facility, that we do treat these children, and that we exist somewhere in state law so that we can have these better policy conversations about who's covered, to what age, and how we could better the services. Thank you.
Thank you for the presentation. Thank you for the responses. I think that wraps our questions on this item. So I want to say thank you for being here and for hosting me on tour last week. It was great to actually meet your patients and the folks that you're serving and seeing the work that you do. So thank you for serving our community.
Thank you, Chair. Thank you, everyone.
Okay, with that, we are officially going to take a brief recess for lunch. It is now 12:05, so if we could come back at 12:35, and then we will reconvene to hear the remainder of our agenda. Thank you. Okay, welcome back from lunch. Thank you so much for being here. I hope you enjoyed your 35 or so minute break. Thank you. Thank you to the folks who prepared our lunch today that work really hard in the legislative building. We really appreciate them supporting us. Okay, we're going to move into the next agenda item, which is the one that we skipped over. So we're going to go backwards before we go forwards. And that leads us at the deployment of seizure safety training in schools with Monica Lopez Morales. Oh, thank you so much. Thank you. You may begin whenever you're ready.
Hello, can you hear me? Hello?
Hello, thank you. Go ahead.
Good afternoon. My name is Monica Lopez Morales, and I am here in support of establishing seizure-safe schools in Nevada. In Nevada, there are 31,000 people who have active epilepsy and thousands of children attending school every day while living with seizure, many of whom don't even realize they're having them. Currently, there is no statewide requirement for seizure recognition or response training in schools. When most people hear the word epilepsy or seizure, they picture someone falling to the ground convulsing. And while that is one type of seizure, a tonic-clonic seizure, it is only one of many. Not all seizures look like that. Seizures are not always obvious. Many are subtle, silent, and can happen many times throughout the day. Some may look like daydreaming, confusion, or brief behavioral changes, while a child may appear fine, but be actually experiencing focal aware seizures or a focal impaired seizure, in which they are not fully aware of their surroundings. And it is in those moments that they are vulnerable to injury, to wandering, or to being misinterpreted. This is why seizure recognition matters. Now imagine spending your childhood experiencing tingling sensations, strange fuzzy feelings, moments of confusion, disorientation, hearing sounds that weren't there, sudden emotional shifts, intense deja vu, brief flashes of light and blurred vision, unusual gaps in memory, and even abdominal cramps. All those symptoms and not realizing until decades later that those were seizures. Well, that was my reality. That is my reality. I have been living with epilepsy for most of my life. I was officially diagnosed at the age of 10 after having a tonic-clonic convulsion at a school assembly. But my story with seizures began much earlier at the age of 5 in kindergarten. In school, this had a profound impact on my ability to learn. I struggled to grasp concepts that seemed simple to everyone else. I worked twice as hard just to keep up reading and rewriting notes to help retain the information. I asked repetitive questions because I genuinely did not understand. And instead of support, I often felt frustration from teachers and embarrassment in front of classmates. I recall sitting in class, appearing fully present, while missing critical pieces of information because I was having seizures, and no one knew. In those moments, children don't understand what is happening and can internalize it. They don't think something neurological is happening. They think something is wrong with me. That turns into confusion, embarrassment, and eventually self-doubt. And that doesn't stay in the classroom, it follows you. Fast forward to today, I have been an epilepsy advocate for many years, and I serve on the advisory board of the Epilepsy Foundation of Nevada. I am also the founder of Eclipse, a mission initiative dedicated to empowering individuals and families with epilepsy. So I have seen firsthand that despite the advances in awareness, there is still significant misinformation about what epilepsy is and how to recognize and respond to seizures. Unfortunately, children have missed medical care, have been misdiagnosed, missed academic support, or received inappropriate discipline because parents and teachers didn't realize they were mistaking unrecognized seizures as tantrums, hearing problems, or simply inattention. Seizures impact how you experience life, how you learn, how you socialize, the activities you participate in, who you befriend, and how you see yourself. Living with it has many challenges alongside the academic ones. There's mental, emotional, and social ones. And these are critical aspects of epilepsy that are not talked about enough. For a child living in a world that can shift at any moment due to unpredictable seizures is frightening. Imagine being a child in class and suddenly realizing a seizure is on its way and it's going to happen in front of your classmates. That fear brings on anxiety, depression, and trauma, and no child should have to experience that alone. Or experiences like went on for decades, like experiences that I went through for decades ago, bullying, mocking, social isolation, these are all still happening today in school. Some children avoided me because they believed seizures were contagious. Some told me I was cursed or possessed. Others were told by their parents not to be near me out of liability. I was labeled the seizure girl or the fire truck girl because emergency responders were frequently called to my school. And while those responses were meant to help, they also created another layer of stress because I knew the financial burden it placed on my family. Today, an ambulance call in Las Vegas can cost the family anywhere from $800 to over $2,000. These experiences shaped my confidence, my identity, and my mental health. And it did not end at elementary. It followed me into high school and college. And to this day, I still carry the emotional weight, all those moments that little girl experienced who didn't understand what was happening to her. Children with these comorbidities become adults with these comorbidities. And this is especially concerning when we consider that Nevada currently ranks last in the nation for youth mental health. But my story is not unique. Epilepsy is the fourth most common neurological condition. In fact, 1 in 26 people will develop epilepsy at some point in their life. But the truth is, you do not need to be diagnosed with epilepsy to have a seizure because every brain has the potential to seize. So anyone, anywhere, at any time can have a seizure. This is why seizure response should be a basic life skill, just like CPR. So this is really about school-wide safety, because seizures can happen in the hallway, the cafeteria, the bathroom. The fear of having one is constant, and knowing that trained individuals are present makes a difference for the student and their family, because epilepsy affects the entire family. Parents sent their children to school trusting that the adults will know what to do. A coordinated care team, including parents, school nurses, and educators, is essential, especially teachers who are often the first to witness these moments. Individualized seizure action plans are also essential because seizures are unique to each child. These plans provide clear, specific guidance so that everyone involved knows exactly how to respond and support that child. But even when seizures are recognized and treated, there are still ongoing challenges that affect the child in the classroom. Children have to learn to navigate life with seizures, triggers, and to manage the effects of the medications used to treat them. Medications affect memory, attention, cognitive clarity, processing speed, fatigue, and mood, and all of that directly impacts a child's ability to learn and function in the classroom. So even when a child appears physically stable, they may still be quietly struggling to keep up academically. Training should include understanding what that child is experiencing. Training that includes real-world perspective and lived experience helps supports this and the student as a whole. When staff understand seizures, they help create a culture of awareness and empathy that reduces stigma and prevents bullying and supports a child's confidence, as well as being aware of the realities that many people don't even know exist, like the post-ictal phase or SUDEP, sudden unexpected death in epilepsy. Too often, these conversations only happen after a tragedy when people realize that someone could have died from a seizure. So this is not just about awareness. This can literally save lives. At its core, this bill creates a system where every adult can recognize seizure and the right people can respond. This is not about asking teachers to become medical professionals. It is about asking them to recognize an unusual pattern so that the child can receive the care that they need sooner, whether that's diagnosis, treatment, or learning to manage triggers that affect their ability to succeed in school. This is about safety, dignity, and mental health, and ultimately a child's future. This proposal builds on existing frameworks already in place for conditions like asthma and severe allergies. The baseline training is free of charge through the Epilepsy Foundation. Districts can then choose to go further through existing professional development budgets, just like they do for CPR and suicide prevention training. Nevada has already shown it takes neurological conditions seriously by recently passing 2 bills, one requiring first responders to receive specialized training for autism. This bill applies the same principle to our schools and to epilepsy. And the other, which puts epilepsy codes on driver's licenses, which is great. It protects teenagers during a traffic stop. But at the same time, that same teenager can walk into a school building every morning where not a single staff member is legally required to know what to do if they have a seizure. At the federal level, efforts like the Seizure Awareness and Preparedness Act and the National Epilepsy Plan are already recognizing the importance of seizure education and response. So this is not a new and untested concept. As of today, half of the states have already passed Seizure Safe Schools. So these are the reasons why we are proposing the Nevada Seizure Safe Schools Act. We are asking for your support because when you change how schools respond to seizures, you change a child's experience, and that can change a child's life. Thank you.
Thank you for your presentation. Members, questions? I don't see any questions. Thank you so much for your presentation. It was very informative, and we look forward to considering the measure as we are wrapping up. Thank you for your policy presentation.
Is there any way that the moms can say something?
Oh, of course. By all means, please.
I'm so sorry, I didn't get to the microphone fast enough. Good afternoon, Chair and members of the Health Committee. My name is Lydia Reed, and I speak to you today as not only a school nurse, but I think more importantly as the mother of a child in the public school system who suffers from significant seizures. My son Aiden is 12. He has suffered from seizures since he was 1.5 years old. And most recently in 2024, he had one that significantly impacted his life. He fell, resulting in a brain injury, and he was in the hospital for 9 days. So I think it's important that we speak about this today because he goes to school every day for 6 hours and 11 minutes. And on a daily basis, I field phone calls, from his school asking me, do you think this is a seizure? Because he suffers from multiple different types, ones that some people have never seen, because it's not just convulsions. They're subtle as an eyebrow raise that never stops or a twitch in the mouth that never goes away. And from a school nurse standpoint, I have students who have never had a seizure in their life. Just a month ago, a kindergartner who suffered her first seizure at school. And I was able to provide her teacher, who was nervous, because that's okay to be nervous. It is a very scary condition. I was able to provide her with the trainings from the Epilepsy Foundation. And when that student suffered a second seizure a few weeks later, she was able to handle that seizure with much more confidence than she was the very first one. So I do think it is very important that we look at this and say, how can we keep our students safe in schools? Thank you.
Thank you. Good afternoon, Chair and the Health Committee members. Thank you for allowing me to speak today. On behalf of this Nevada Seizure Safe Schools Act, I'm sorry, this is tougher for me. So my name is Lisa Griggs, and I'm here today because I lost my son, Judah, to SUDEP, which, as you just heard Monica explain, is sudden, unexpected death in epilepsy. I also represent Faces of Epilepsy. It's a nonprofit. It was created in Judah's legacy to bring awareness and education and support families that are affected by epilepsy. Judah was born here in Nevada. He loved music and playing drums in our church, and he was deeply loved by our family and community. He also experienced seizures at school, which means our family lived with the fear and just insecurity that many parents do face with epilepsy every single day. And no family should ever learn about SUDEP after they lose a child. Awareness is not just about information, it's about preventing these emergencies, reducing the risk and trauma, supporting mental health, which is a huge piece in seizure safety, and creating safer environments for our students before crisis happens. Early awareness and preparation can save lives and help avoidable tragedies. Families living with epilepsy often live in constant fear and anxiety and emotional exhaustion. And children, because they spend so much of their time at school, Parents should have and trust that the adults that are caring for their children are prepared to recognize these seizures, respond appropriately during these emergencies, and then help create safer spaces for epileptics. 25 states have already enacted this legislation into schools, yet Nevada has not. So we're asking for your help today, that you would choose to help us to get this passed. I cannot bring Judah back, but what I can do is I can continue to advocate through my own grief that this would be something that you would seriously consider. And I respectfully ask for your support today in this act. Thank you.
Thank you. That does officially conclude your presentation, yes?
Yes.
Thank you. We do have one question from Assemblymember Edgeworth.
Thank you, Chair. What a great, important thing that you've brought to our attention. I can hardly imagine anything more terrifying than having a child who has seizure disorder or having seizure disorder. I'm curious, and this is probably a little in the weeds, so you may not have the data right in front of you, but I wonder if in the 25 states that have implemented laws like this, if there's any data to support decreased mortality or morbidity or increased diagnosis or anything like that that would help to support this bill?
As of right now, there is not, because this is new. All of these states have pretty much done this within the last 2-3 years.
Thank you. Thank you, Chair.
Thank you.
Also, Assembly Member, can I say one thing about
please, I need you to state your name for the record, though, so our secretaries can identify who's talking. Thank you.
It's Lisa Griggs, and SUDEP, because the mortality rate, a lot of with regard to SUDEP and the death with regard to epilepsy, a lot of the numbers are off with regard to the coroners. So it's hard to get accurate numbers even around SUDEP. 1 in 1,000 epileptics die of SUDEP, whereas that's such a high number comparable to diabetes could be 1 in 250,000. So it's very, very common, but yet the numbers probably aren't accurate anyway because of the coroners. We're trying to pass more laws, obviously, with that as well.
Right.
Thank you.
Thank you for that clarity. And thank you for being here. Thank you for sharing your story and your vulnerability with us today. I'm so sorry for your loss and appreciate that you are bringing forth legacy proposals in order to honor the passing of your family. Okay, thank you so much. That brings us to the next item on our agenda, priorities of Nevada's Regional Behavioral Health Policy Boards, with Maddie Larson and Shayla Holmes from the Northern Board, Katie Metz from the Washoe Board, and Valerie Kaihupe. I'm going to mess your name up. I'm so sorry. And Chair Fergus from the Rural Board. So if you are here to present on the Behavioral Health Policy Boards, please come forward. I'm hoping that you all have this coordinated, and you may begin whenever you're ready.
Maddie Larson for the record. Fergus Lawfridge should be going first from the Rural Regional Behavioral Health Policy Board online.
Good afternoon, Madam Chair. Fergus Lawfridge, the chair of the Rural Regional Behavioral Health Policy Board, pitch hitting in for Valerie Haskin, who put together the one-pager that was provided for you on our priorities. We do represent, as the Rural Regional Behavioral Health Policy Board, Elko, Eureka, Humboldt, Lander, Pershing, and White Pine counties, and have a multidisciplinary team on our committee with representing from courts to law enforcement. Senator John Elson is on there with Judge Michael Montero. We have a county judge and other practitioners, hospital CEOs being represented. Within our one-pager, we identified, because we're such a rural and vast area that we cover, a number of priority items for this year. You'll see there access to care, insurance, workforce development, quality of care, and support of local efforts. Madam Chair, if you would allow me, please, to just give you a little background color on the priorities as we can flesh that out, maybe help your joint committees as we go forward. Things that are associated with us that we're really looking at are access to care, which is three-faceted. It's the physical access, which is safe, affordable, non-stigmatic, and timely transportation, particularly to and repatriation from centers where they have to be treated. Typically that happens within our rural communities, going to Reno or even all the way to Las Vegas just so they can have treatment. But then we get them there, we have to bring them back home. And so those create tremendous barriers for our community members seeking care. Physical distance often creates those logistical issues, being able to schedule care at times that patients make it a timely manner. We have a mechanism within Nevada Medicaid that they oversee with the scheduled transport, but often these transports require to be in a secure vehicle, and also they can't be scheduled. The next is the financial access. Some insurance companies are still not providing adequate coverage for necessary care. We've heard that previously with the parity and things like that could be an issue. Insurance payer types often affect a patient's ability to access care if the providers cannot accept that type of insurance. Some patients may not have the ability to meet co-pays for treatment, particularly for specialized providers or prescribed medications. Additional expenses associated with this accessing treatment is such as purchasing fuel to even drive to the services. You know, I'm a health director for a very rural tribal community that's 75 miles from a hospital or a town where they could get service. So that creates a barrier. And then the availability and capability of services. The chronic lack of providers of all types, we've heard this, we're addressing that. Both your bodies have worked on this over the years to help us with that. And so we're addressing the pipeline, but we still have those gaps there. Very special populations create additional barriers to accessing care. Members of the board and our rural behavioral health coordinator, we've received information from providers and from the community of the inability of providers to join insurance networks, even in documented provider shortage areas. So providers want to join, want to be able to help, and the insurance says, we got enough. We got enough. We don't need you. And that's even in our provider shortage areas. Insurance, as we've heard, is going to continue a big problem as we go forward, both for our regular private insurances and with Medicaid, as many of our recipients of behavioral health services across Nevada are recipients or in the Medicaid, managed care, or fee-for-service programs. So there's very limited coverage. Some payers may only offer a very limited number of sessions. We know that behavioral health is an ongoing condition that requires extensive treatment, and sometimes they're capped out. And when you hit that cap, nobody can help you. Many patients experience this lack of coverage of non-emergency secure transportation, as we've mentioned, or emergency transportation. The board continues to support current and planned efforts to remove barriers to care for rural residents covered by both public and private payers. There's always the insurance process of the red tape. Our board will support or advocate for the reduction of streamlining of procedural barriers, such as onerous prior authorization processes, as we've heard today, and clinically unnecessary requirements to qualify for appropriate and timely treatment of services. The limited reimbursement of providers. Many insurance providers do not reimburse adequately for services, but most notably, Centers for Medicaid Services or Medicare Services and Nevada Medicaid reimbursement historically low. In fact, recent research shows that those rates have not been addressed for this particular provider type 14 for over a decade, and the Nevada rates are significantly low. Cost of doing services continue to rise, but their cost of a fee schedule remains exceptionally low. The board will continue to support and advocate for efforts to improve reimbursement efforts that are underway and those that are in the future, as we heard about the parity today. Barriers in network care, as we've mentioned, some eligible providers are not being allowed to join insurance networks, which claim that the networks are full, regardless of whether or not the provider will be serving a recognized provider shortage area. Workforce development, the number and types of providers available. Proper resources must be allocated to support statewide efforts to educate and place providers in shortage areas across the state. While we look at the rural, we're looking across all the state. We will continue to focus on resolving inefficiencies and challenges related to providing provider licensing and credentialing. Training and best practice in telebehavioral health. Ensure that providers who are working with clients via telehealth mechanisms are trained in best practices for telehealth treatment of behavioral health services. There are standards out there. We have not implemented those necessarily here. This includes identifying proper protocols for including in-person contact when necessary during crisis scenarios to maintain patient safety. Let me go to quality of care. Improved care transition. We've heard some talk about this today. There is a dire need for improved systems to ensure patients are connected to the care they need in a timely manner, regardless of who is staffed at various organizations. Major improvements are needed in discharge planning to protect the health, well-being, dignity, and continuation of care for patients when they're the most vulnerable. Improved communication among providers. Need for HIPAA compliant platforms used by all providers for the continuation and coordination of care. Increase the use of business agreement models or MOUs among various agencies and providers for coordination of care, expansion of assisted outpatient treatment and or assertive community treatment programs for persons needing intensive care in specific communities. Increase the safeguards to quality care. This board will support programs to evaluate and improve the efficiency and quality of service provisions across the state, but most poignantly, the rural region that is underserved. We continue to support local efforts, collaboration and support for aligning efforts of local coalitions and agencies. The board will work to support and evaluate the efforts of local and regional groups that are aligned with both the needs of the community and the evidence-based practices. We believe that there's strength in numbers. We are oftentimes siloed and just do our thing. If we can spread this across our region, this is where we'll have the most support in those collaboration efforts. Support the use of opioid settlement funds that the counties receive. The board will support local government efforts to use those funds in a way that both meets their intended purpose, addressing the opioid epidemic, as well as meeting the needs of the community. Members of the board and the Rural Regional Behavioral Health Coordinator may provide technical assistance or contact technical assistance resources to planning groups as able and appropriate. Expansion of the local behavioral health task force. We've seen this in some of our counties and communities, and we'd like to continue this. The board directs the Rural Regional Behavioral Health Coordinator to support capacity building of existing local behavioral health groups and promote the creation of new groups as appropriate. And in closing, just for the Rural Regional Behavioral Health Policy Board, we are looking to the two things, the parity being one of the top ones, and then the Medicaid fee schedule for provider type 14. As we're seeing a number of our providers, we're talking about a shortage area. We're talking personnel, we train them. We have the School of Medicine's program that's putting out new individuals, but they're finding they're not having a place to go, or the business that they're going to is closing. I have one that I'm working with here in Southern Nevada right now that has in dire straits because they're not able to make that reimbursement on the patients that they have. So those will be our priority areas, and we look to both of your bodies to help us as we move forward. And with that, I'll turn it over to my other colleagues in Carson City.
Good afternoon. Shayla Holmes, Chair, Northern Regional Behavioral Health Policy Board. The Northern Board serves Carson City, Churchill, Lyon, Douglas, and Story counties. I believe you guys have a one-pager in front of you. I'm not going to go over our priorities. I would just note that they're not in any particular prioritized order, although they are numbered. While the Northern Board has yet to solidify its BDR concept for the next legislative session, we're currently exploring several concepts. Those are down at the bottom of the one-pager you have in front of you. There's 5 concepts we're currently exploring. 3 within Chapter 433A. So the first one, strengthening legal hold transportation, you heard through the rural presentation. Transportation continues to be a concern and an issue. Particularly what we're wanting to explore is 433A.160, number 2, who is able to do a legal hold transport. There's currently 5 options listed in there. The number 1 option that's available to the majority of our counties and most of the rural areas of our state is law enforcement, which becomes a barrier and an issue to timely response and ability to get folks connected to care as they need it. So we want to explore that and look at alternatives and what those impacts could potentially be. Looking at expanding provider types on who can discharge a hold, 433A.197. Right now, the level of credentialing required to discharge a hold is an MD, a psychiatrist, psychologist, APRN. It also allows for a licensed clinical social worker with additional training. This excludes licensed marriage and family therapists and licensed clinical professional counselors. So we want to explore what that could look like to add those credentials to that ability to discharge and what impacts that could have potentially going forward with that one. We also want to look at discharge planning, 433A.713. I appreciate earlier Senator Titus mentioning the safe discharge and what that looks like already for professionals. Right now in NRS, it allows for State Board of Health to adopt a plan, and we're exploring what recommendations or requirements could aid individuals if that plan was developed and implemented. Right now, it's not utilized. So we want to see if there's anything that could be done there or if anything needs to be done there. And last but not least, again, we're exploring all of these options, is looking into Chapter 458.033 at the relationship between our prevention coalitions. So right now, they're currently identified as certified substance use coalitions, and we're looking at potentially wanting to expand that certification to include behavioral health, and or there's several things within this chapter that are being explored, identifying coalitions as lead agencies and allowing for them to be able to subgrant, and as well as expanding other portions of 458 to enhance community coalitions' reach and their coordination. So our next board meeting is Thursday, May 21st at 1:30, and we'll have focused presentations on all of these concepts with the goal at that meeting to be able to identify which one we're going to move forward with and then start working on identifying that language and solidifying more of these concepts. I believe with that, we'll pass it off to our other peers.
Good afternoon, Chair Brown May and members of the committee. My name is Mark Funkhauser. That's spelled Funkhouser. I'm the Southern Regional Behavioral Health Coordinator, and I'm here on behalf of the Southern Regional Behavioral Health Policy Board. This region consists of Mineral, Lincoln, Esmeralda, and Northern Nye counties. And I'm here to give some information on the priorities for the board leadership and in this southern rural, frontier, and tribal region. Many of the issues that you've already heard about are going to be recurring. I think one in particular, the Southern Policy Board proposed a bill last session on non-emergency secure behavioral health transportation. And in that bill, the current statutes suggest that they only pay for loaded miles, which is when the person is in the vehicle. And so part of that bill, we wanted to increase that to unloaded miles. So essentially a round trip with whether the patient was in the vehicle or not. The other two components of that bill that the board put forth was an increase of 10% statewide Medicaid reimbursement and also 15% for rural areas. That bill did not pass, but the board may well consider, after talking to partners and state partners, may sort of revive that or repropose that bill. The other areas, you heard common themes, is workforce expansion. Peer support specialists and community health workers are big components of the clinical, non-clinical spectrum of services. In the southern rural region, it's probably one of the most under-resourced areas in the state, and there's not a lot of peer support there. So that's one of the areas, a special focus of mine as a coordinator and also the policy board. There are more community health workers there, but we believe that we could use more community health workers and peer support specialists in that region to support the clinicians and the work there, either in deflection and diversion or in the clinical realm. The other big aspect of the southern region, especially in places like Tonopah, is there's not a lot of clinical support there. There's no hospital there in Tonopah. It's in northern Nye County. If you know the geography, there is Desert View in the Pahrump, which is closer to Las Vegas and quite a bit far south, and they're over an hour away from Mount Grant, which is in Hawthorne. So there's no hospital, and they have a rural clinics there, but there's no clinician there. So it's the coalition, the Nye Communities Coalition, serves that area. So there are some peer support specialists and community health workers that work there, but So I often think of Tonopah as sort of right there in the middle of the southern central region that is really under-resourced with regard to. And then Esmeralda County is about 20, 30 miles south. And so obviously they don't have a lot of resources at all. So they often actually go to Bishop, California for EMS and things like that. So that also brings up the transportation factor. So integrating those peer support specialists and community health workers into health and justice and community systems is definitely a priority. Another priority, which is a longer term and bigger issue, as you know, as far as housing. But one option that that this board has made a priority and is looking at is like peer respite or living room models to assist. This would actually alleviate transportation because they would be peer respites in those areas where people could actually be taken, much like, it wouldn't be like the crisis centers in the urban areas. You know, they wouldn't take people who had a severe crisis, but they could take these folks to these peer respite homes, which would be staffed by peers to get settled down. And once they are, you know, able to utilize this housing for short-term or temporary, they could potentially go back into their own community and their own homes and things. So that's one option, just addressing those housing barriers impacting recovery. The other big priority is deflection and diversion. The deflection and diversion in the state sort of started out in the Carson City area, in the northern region here in this surrounding area. There is some deflection and diversion in the southern Nye County in Pahrump, but there's not really much deflection and diversion in the other parts of the southern region. And that would be something that we would support and try to cultivate that growth in that region. The other big priority, especially as a coordinator and with this board, is to support the 988 Crisis Response Project. It's the state has done a great job of rolling that out and, you know, expanding that, but we're working with them on bringing that more into the rural areas. And, you know, there's crisis centers in Clark and Washoe, but there's 988 town halls, you know, going on in the rural areas and trying to roll that out into the rural and frontier areas. The other big priority for the board and also actually for the coordinator, and we're working with the state on, is data, trying to improve the data sharing and also to assist the coordinators to be able to help collect and support the collection of that data on crisis holds and things like that. That's statutory. It's been in the statutes, but you know, we struggle with knowing how to support that. And so we're working with the state on that regularly. The other big priority is access to care. One of my big concerns is that we talk about telehealth a lot. It's really grown, obviously, since COVID. It's here to stay and it's viable. But we don't often talk about how to bridge the gap between in-person and telehealth. It kind of goes back to what Senator Donate mentioned earlier as far as how to coordinate those services in between and among providers. We can't just have a warm handoff with those kind of things. We need solid transitional support between jails and hospitals for those people coming out of care. And so that concludes my outline of the priorities for the Southern Regional Policy Board, and I want to thank you for allowing us to be here today.
Good afternoon, Madam Chair and committee members. My name is Katie Metz, and I serve as the Washoe Regional Behavioral Health Coordinator, supporting the Washoe Regional Behavioral Health Policy Board. My role today is to share information regarding the board's identified priorities and ongoing discussion around policy considerations for the committee's awareness. Washoe County serves more than 500,000 residents, and like many regions across Nevada, Washoe County continues to experience increased demand for behavioral health crisis response services, substance use treatment, supportive housing, youth behavioral health supports, and workforce capacity across systems. The Washoe Regional Behavioral Health Policy Board is composed of representatives from healthcare, behavioral health, law enforcement, public health, recovery services, and the justice system. The board works collectively to identify regional behavioral health needs, strengthening cross-system coordination, and provide regional input related to behavioral health planning and system improvement efforts across Washoe County. Regional planning efforts, needs assessment, stakeholder engagement, and ongoing system coordination have continued to identify challenges related to sustainable behavioral health crisis response funding, access to diversion and community-based services, supportive housing and treatment capacity, workforce shortages, and the need for stronger behavioral health data sharing and regional planning efforts. In response to these identified needs, the board has identified 5 priorities. One of the board's primary priorities is continued development of a coordinated behavioral health crisis response system that ensures individuals have someone to call, someone to respond, and a safe place to go. Current regional accomplishments helping guide this work include continued development of Washoe County's crisis response system infrastructure and expansion of regional coordination efforts related to 988 and behavioral health crisis response, development of a crisis navigation and warm handoff tools, and increased collaboration across healthcare emergency response and behavioral health systems. This work also overlaps closely with our diversion and deflection efforts, such as Washoe County's sequential intercept model framework, which is intended to reduce unnecessary justice system involvement for individuals experiencing behavioral health challenges by strengthening coordination and connections to behavioral health care, crisis services, housing, and other community-based supports. While important progress has been made, continued investment is still needed to strengthen crisis stabilization capacity, mobile crisis response, and long-term sustainability funding, and interoperability between behavioral health and emergency response systems. The board also remains focused on strengthening substance misuse prevention, recovery supports, and workforce capacity across the region. Current regional efforts include expanding peer support integration, strengthening recovery-oriented systems of care, and increasing collaboration with behavioral health providers and community partners. Another board priority is strengthening behavioral health preparedness during, before, and after emergencies and community crises. Current regional efforts focused on trauma-informed planning, integration of behavioral health into emergency response system, and coordination with regional emergency management and public health partners. The board also continues to align behavioral health priorities with the broader community health goals. Regional accomplishments include participation in the community health needs assessment efforts, strengthen collaboration across systems, and development of a data-informed planning initiatives to better identify service gaps and community needs. Behavioral health data and regional planning continue to guide the system. Recent accomplishments include completion of regional behavioral health and housing mapping, development of regional data briefs, and identification of service gaps and opportunities related to treatment access, housing, crisis response, diversion, and coordinated care. Based on these identified priorities, one policy consideration currently being discussed by the board relates to the long-term sustainability of Nevada's behavioral health crisis response system, including 988 mobile crisis response and crisis stabilization services. As part of those discussions, the board has identified interest in continued evaluation of the existing telecommunication and cell phone surcharge established under NRS 433.708 as one potential mechanism that could help support ongoing crisis response infrastructure, mobile crisis response, crisis stabilization, and regional system coordination. The board has also discussed the importance of continued attention to enforcement and compliance with the Mental Health Parity and Addiction Equity Act to support equitable access to behavioral health care and substance use treatment services. And we are aware that such as the Rural Regional Behavioral Health Board is interested in this BDR proposal, but our board is more than happy to support in those efforts. So that concludes where the board is at. We are having our next meeting on June 8th. We currently have questions out for the LCB around the increase of the surcharge phone for the 988 mobile crisis response and crisis stabilization services. So we'll be working on continuing to explore that BDR policy and any others that come up at the June 8th meeting. So I want to thank you again for the opportunity to share Washoe County's behavioral health priorities and ongoing collaborative efforts. We appreciate the committee's continued support for behavioral health system development and regional collaboration throughout Nevada.
Thank you for your presentation. We do have one other board. I'd like to defer to Senator Dunyate to talk for a minute just about the Clark Behavioral Board.
Thank you, Madam Chair. Obviously, I think the part of the sentiments that were being heard today, I think it's important that the policy boards all continue to do their work. It's my understanding that the Clark County Regional Behavior Board has been having difficulty meeting, mostly because of the internal structure with the coordinator. And so I think it's imperative for the committee members to make sure that we are following through and making sure that that position is filled through Clark County. It's my understanding, based on conversations with Clark County, that they are in the process of it, but I think the time is of the essence given that the bill draft recommendations are coming online. So I don't know in terms of the specification of whose line item it falls under, or if other coordinators can help support the Clark County Regional Behavior Board just to get themselves some footing while we're looking for a coordinator. But I think, I mean, given that it is the most populous county in the state, I think it's imperative that we continue to meet and do the work that they need to. Thank you, Madam Chair.
Thank you. I want to thank you all for the presentation. I think it's very important, especially today, that we're focusing on the progress made and the priority recommendations that are coming from each of your boards. It's my understanding that each one of the behavioral health boards does have a singular BDR, so I thank you for the work that you continue to champion to support our population. And with that, we will officially close this agenda item. Thank you all for reporting today. Okay, that leads us to the next item on our agenda, update on Nevada Medicaid's Children's Behavioral Health Transformation Plan. Thank you so much for being here and waiting all day with us. It's great to see you. You may begin whenever you're ready.
All right. Good morning or good afternoon, Madam Chair, committee members, and Jensen for the record. I am the Medicaid Director here in Nevada, and I thank you all. I know it's been a long afternoon. I will go at a high level to provide some updates on our children's behavioral health transformation. There was particular questions related to some of the funding mechanisms, so I'll spend some time on that, and then happy to speak to any questions that you may all have in more specificity on these items. So again, as I mentioned, I'll cover a quick update on that project overview as well as the tax funding and a look ahead at this year. At a high level, our children's behavioral health transformation is a crucial project we had the opportunity to share with this committee a number of times, but I think it's helpful to always take a step back and think about the 10,000-foot view. This is a statewide project to improve outcomes for kids with behavioral health needs in our state. Nevada is 51st in the country in outcomes for kids with behavioral health needs. I know I'm not the first person to share that today, and I know that reality is something that we all take very seriously and are not happy to live with. And so I'm grateful for the incredible partnership that I've had with each and every person that's presented throughout the course of today to really help me better understand the realities of our system and where we can continue to improve. As we talked about, before I get into, the settlement agreement itself, I do want to start with a quick overview on the vision for our transformation. As I mentioned, no one wants to be 51st in anything, especially not in something as serious as the health and well-being of our children in this state. We have an opportunity right now to make a really concerted effort to start to turn this ship in the direction that we all believe we need to go. But if we make a system transformation that isn't aligned with what kids and families actually need in this state, it will be an opportunity wasted. So what we take very seriously in each and every policy decision and delivery system reform is getting real feedback from kids and from families and from providers on how to do this in a way that will actually work. Not how it will work in Ohio or Arizona, but how it will work in Nevada, because it will be a unique model that's going to have to be a little bit different. Our goal and our vision is that all children in Nevada have access to behavioral health services they need to live and to thrive with their families and in their communities. So this transformation itself, our work really began nearly 2 years ago. In April 2024, the Interim Finance Committee approved the first kind of bolus of funding to establish the Medicaid efforts in this vision. Later, about 8 months later, a settlement agreement was signed between the state of Nevada and the U.S. Department of Justice. That's in response to findings from a few years earlier that the state of Nevada was out of compliance with the Americans with Disabilities Act for essentially over-institutionalizing kids with behavioral health needs who would be better, more appropriately served at home and in their communities. Again, that settlement agreement is effective January of 2025. It's a lengthy and really crucial document with about 148, if I remember correctly, items the state will accomplish to come into compliance within the 5 years preceding that signature date. Importantly, there's a lot of questions on who does a settlement apply to and what does a transformation itself apply to. Because of the way our federal ADA is written, it is tied to children and youth that receive their health coverage through a public program. And in Nevada, that means Medicaid. So about 1 in 2 kids in our state receive coverage through Medicaid. And specifically, there's what's called a focus population in the settlement. And that is all kids in foster care and all kids that have complex behavioral health needs and are essentially highly utilizing various aspects of our behavioral health continuum that they would be better served in more community-based settings. I'll share some detail in the next slide about what that actually looks like. But importantly, it is a narrower set of youth that we're focused on through the settlement. The transformation is intended to be more broad and support kids across our Medicaid population. I will note, though, a lot of folks are looking towards the other half of the kids in our state that receive coverage outside of our Medicaid program. And we, unfortunately, do not always have the legal or kind of levers that we do on the Medicaid side to make these same changes. But we're hopeful to see the private market continue to make efforts to align with what we're doing in Medicaid because we believe it to be not only innovative, but the right thing to do. As I mentioned before, youth and family voice is a crucial component of this work, as is a really accountable system that's reflecting all state and county agencies that are involved in supporting these kids and families. So with that effort in mind, we launched a working group back in October of 2024 that meets monthly, and now they requested to meet bi-monthly for a little bit longer to reflect folks' schedules and life commitments to inform each and every decision that we make. So every policy that you'll see reflected in the next slides has been reviewed by this working group, and their input has been reflected. That working group is made of parents, of youth and youth advocacy groups, of providers across every phase of the behavioral health continuum, and a range of community advocates, state sister agency partners, and county partners to really ensure that the right people are all at the same table as we review and make these decisions. As I mentioned, the settlement is a 5-year commitment. We're in this for the long haul, though. This is going to be a long transformation. I had a great conversation with a peer in New Jersey yesterday, and they were sharing about their efforts, and they've been at work on this for 26 years. They now have the fewest residential and inpatient admits for youth in the entire country, but they said it really took them about 26 years to get there. And so I'm grateful that we can learn and hopefully move more quickly because we can draw from their experience, but we recognize this is a long commitment and one that we will continue to reflect in our priorities and our budgets moving forward. As I mentioned, here's some initial data on our focus population. So again, I like to think of this as a bit of the tip of the triangle. These are the kids in our state that are covered by Medicaid, that have the most complex behavioral health needs and are involved in a lot of our systems, like mobile crisis, inpatient care, or residential care. Right now, there's about 2,000 youth that are identified to be part of this population. The reason that line is going straight up is because this is a year-to-date calculation based on the way the settlement is written, meaning there are 0 children in the focus population before the settlement is signed, and every month since then, we look at the kind of healthcare utilization and diagnoses of kids in our population in that month and assess whether they're part of the focus population. So we expect those numbers to continue to rise over the course of this year and then level out once we have about 12 months worth of data. Our hope, of course, is that they go down over time as fewer kids develop these more high acuity levels of care. Right now, again, as I said, about 2,000 youth through September, so about 9 months worth of data. Importantly, and perhaps not surprisingly, 66% of them are teenagers. I think very interestingly, almost 6 in 10 of them are girls, which I think reflects the national trends of behavioral health concerns we're seeing. 1 in 3 of these kids has a diagnosed substance use disorder, and 1 in 3 has an intellectual or developmental disability. We call that often dual diagnoses. I recognize a lot of kids live with more than 2, and that's the reality of kind of the clinical and social context that our youth are living in. And that means that they're engaged in a lot of different state systems. And so that's why it's crucial for us to continue our work with DCFS and with DPPH and with ADSD to ensure that these youth that we are all touching in some ways, we have a better sense of exactly what they need for their care. I did mention at the bottom, about 16% of these kids are involved in foster care themselves. As I mentioned, the settlement calls for delivery system reform for all kids in foster care, though, regardless of their behavioral health clinical need, recognizing that there's a very specific need for that population that we could serve better than we are right now. If folks are interested, we have a full data dashboard that's available on our website, a lot of good detail there that I would recommend folks take a look at if you're interested. So this is a slide that I often use to try to put a visual or put into words what we're doing here in the transformation. And I'll ask you to bear with me with some Medicaid speak because this gets a little bit complicated. But I think at a high level, there's 3 really important questions about the transformation. Number 1, what benefits are available? Meaning, what will Medicaid, as a payer, pay a provider to deliver as a healthcare service? Number 2, what's the delivery system? That's really whose name is on the front or back of your insurance card. Who is adjudicating claims, supporting care coordination, and ensuring that the program is successfully run. The last and probably most important question for most of us is, how do you actually access these services? What's the front door? Right now, I'll start at the bottom. Our care coordinators at district offices and managed care organizations are really that front door. We recognize, though, they don't always have the specialized training and support that these kids and families need. So what we're moving towards is a local model that's driven by providers that enroll with Medicaid to do exactly this, to help families and kids navigate our system in a way that's based on national evidence-based practice and is reimbursable under Medicaid in a way it's not right now. So if you move to the top again, this work began in 2024, and the arrow at the end of the timeline is an important one. It will continue, but I think these 3 years are what I really want to focus on. Since we first received that funding in April of 2024, we've been hard at work to expand the way Medicaid pays for services we already cover and starting to cover new services to really right-size where we are investing our funds in this behavioral health continuum. I'll share more detail in the next slide on what those services are, but they really range in their effective dates from January 1st, 2025, all the way into 2027. I may be one of CMS's most favorite Medicaid directors these days because we have a total of 42 state plan amendments in process with them. And to pull off this transformation, it takes a combination of 5 different federal authorities, which they have acknowledged as perhaps one of the more complicated things states have tried to pull off, but they've been incredibly collaborative and eager to help us continue this path forward. The next question is, what is the delivery system? So as folks know, whose name is on the insurance card? If it's the state of Nevada, that means you're part of our fee-for-service program, where the state directly funds and adjudicates the program. For the first 2 years of this transformation, that population include any kids in our rural communities, as well as kids in foster care, whereas kids in our urban communities were part of the managed care delivery system. Effective January 1st, all kids across the state moved into managed care with the exception of our foster care population, who will remain in fee-for-service until we have our new delivery system. That blue rectangle or box at the right is really the most crucial thing that we're building towards, which is a specialty plan specifically designed for kids in this population. It will include the full Medicaid benefit array. We're trying to take a whole child approach and not separate our brains from our bodies in the way that insurers pay for services. And it will include specific behavioral health services for kids and families. We'll also include that enhanced care coordination work that I mentioned earlier and a really robust screening and assessment system to help make sure kids are identified as early as possible and connected with appropriate care, and that is continued, that plan of care is reassessed on a regular basis to continue that support for families. So that's kind of the way we picture it at a high level. I'm going to do a quick overview of some of those benefits changes. This is how I like to visualize where we are in our current state and where we're headed. So that dark blue bubble is the residential or inpatient component of our behavioral health continuum. It's the highest acuity and it's the most expensive. We are spending nearly 70% of our children's behavioral health budget right now on that blue box, or that blue circle. That blue circle should not go away in our future state. I'm really grateful for our high quality residential and inpatient providers, but we are relying on it too much because there are not other options available to support kids and families. So what we're doing is diffusing funding and new coverage to those other bubbles, the outpatient community-based services, crisis response and stabilization, and early identification, things like our school-based services and other ways to really try to connect with kids where they are as quickly as possible. So the full continuum is touched on in the settlement and something we're focused on. This is a summary with a lot of detail on what we've done to try to improve it. I'll speak to this at a high level and happy to answer any questions. But fundamentally, we're adding new services, outpatient services, including family and youth peer support to help people that have lived experience navigate these systems. We're also adding that enhanced care coordination I talked about, as well as respite care to give caregivers a break and really help kids maintain their placement in those family units and help them to be as well and as sustainable as possible. We also recognize there's things we cover in these buckets right now that, as many folks who presented before me noted, probably are not paid for in a way that's reflective of the cost of delivering care. So what we've done, we had a significant rate increase that we implemented for outpatient behavioral health services that kind of lifted the base level of payment for outpatient services to kids. But importantly, we're also trying to tie those rate increases to quality of care and to say we can't just infuse more money alone. We also want to put our money where we believe the highest value care is. So for the outpatient services, we've developed add-on payments. So providers are paid more if the service is delivered in a rural community setting or if the service is delivered within a child or family's home, intending to really incentivize the types of services that we have the largest trouble accessing for kids and families. The other quality payment we've implemented is on the psychiatric residential treatment facility side. This is pending CMS's approval, but the intention is to reflect when PRTFs are performing at a high quality of care, based on quality metrics that kids and families themselves actually contributed to in our working group, they would receive an additional kind of bump on their per diem payment. We also recognize that staffing levels are going to vary depending on what types of kids are being served in these facilities, so we're also getting creative with ways to reflect payment based on the complexity of the service delivery that they're providing. So again, I'm happy to speak to any of these, but at a high level, a lot of work to add new services, pay for things more and better at the most basic level, and happy to speak to those. My second to last slide here is really about the funding mechanism. So this is where we dive a little bit deeper in the Medicaid wonkiness, but it's a really important component of this work. Fundamentally, our transformation is funded by a portion, 15%, of our hospital provider tax. That revenue is reserved in an account to fund kids' behavioral health initiatives. That account is then used as the state share of our Medicaid services. So as I know Director Weeks had shared with this committee a few weeks ago, Medicaid is a very unique program because it's a blend of state and federal dollars. So we're able to draw down about 60 cents of every dollar from the federal government. Importantly, we don't get those 60 cents unless we put our 40 cents on the table. And so this is our 40 cents, essentially. This is our state share for these services. When the program was designed, we projected what that rate would be that we'd collect in revenue each biennium to really fund these services. That's what you're seeing in those blue boxes here on the slide. I'll talk through what those changes look like because of HR 1, but fundamentally, we are still projecting that Medicaid will have sufficient funds to cover the services we need to really continue this transformation as we have planned. That's the good news. The challenging news, as I know our hospital association partners shared, there is less money that will be collected through this program, and so we will have to be thoughtful about how we continue to expand and build our efforts moving forward. So the chart I'll walk through here, the first kind of group of bars on the left is the next biennium, 26 and 27. As you'll see, those are all pretty much the same size. We don't expect significant impact to this program until the biennium after that, 28-29. When we expect to receive about $25 to $30 million less than projected. Importantly, both of those are still right around $90 million that we will be collecting in that biennium. And again, that is over doubled with the federal match, which is why we feel confident we can continue to fund these services based on our projections so far. We'll continue to monitor this closely, but we are being very thoughtful about, again, building a program not just for the next 2 years, the next 5, but the coming decades that will really benefit kids and families in our state. So with that, I'll close with just a quick summary of where we're headed. There's a lot of work to be done to develop this delivery system that we'll have more details on this summer. We're really focused on that psychiatric residential treatment facility side and launching a new level of care that's a little bit of a step down or group home type model, a residential behavioral health model that came out of last session that we'll be implementing this summer as well. And then we'll head into next year where we're developing care coordination, preparing for that go live, and continuing the benefits in my many meetings with CMS to get these things approved. So fundamentally, we're continuing our efforts both to support kids and families in the short term, right now, and build a long-term system. We've assembled a new team that does specialized care coordination for kids and families that works for Medicaid today. I'm deeply grateful for their work, and so I think if you all are encountering kids or families that need support navigating our Medicaid system, please don't hesitate to reach out. Don't wait until there's a new system or a new benefit. There's work we can do now to support, and we really want to do that. So with that, I'll close, and I'm happy to stand for any questions.
Thank you for your presentation. Thank you very much for your optimism and your hard work, your smile in the afternoon. We do have a question, Assemblymember Edgeworth.
Thank you, Chair. Thank you, Director Jensen. What a great high-level presentation this was of such a complex topic and such a heavy lift. I have a very quick question, I think. I know that you have been working on this for a few years, and I see that on slide number 11, where you said that there's specialty plan procurement that's set for the summer of 2027. I've had some feedback in the community that there have already been some RFPs solicited for this topic. So my question is, if there have been a couple rounds of RFPs, are you changing the RFP? Did you not get sufficient feedback or sufficient applications?
Madam Chair, committee members, and Jensen, for the record, thank you for that feedback and for your question. I'm happy to clarify there. So you're right. Our first procurement that we published was in fall of 2025 for that specialty plan. Based on the bidders that submitted proposals and our feedback, we really realized in conversation with the Department of Justice and our independent reviewer, we needed a revised approach. And candidly, we needed more time to develop the provider network in our rural communities. And so what we had moved forward with, and I think we had discussed this with a few members in the Interim Finance Committee a few weeks ago, we have published a second procurement based on that feedback, again, from our federal partners, our independent reviewer, and our community here, that has a little bit more of a staged geographic approach. So starting with our urban communities and then expanding to our rural communities shortly. As we shared, that process is still in the works. That procurement is underway, and so there's some confidentiality there. But I'm happy to share that we are really committed to procuring a delivery system that works for Nevada and is sustainable and affordable to us. And so we'll continue to learn and develop that process while also trying to move as quickly as we can. And I hope to have more updates for you all soon.
Thank you. Thank you, Chair.
Thank you. Next, we'll go to Senator Titus.
Thank you, Madam Chair, and thank you for your enthusiasm. Sometimes I think it's a big lift, but you always come prepared and enthusiastic, so thank you for that. I just want to address, again, at that last interim finance, we heard that you weren't going to roll to the rules at this time, although that was frustrating for me to hear. I certainly understand that. But what does it look like when we're talking, in this presentation, specifically page 9, where we're talking about respite care? Are there any things available in the rural areas at this time?
Madam Chair, committee members, and Jensen, for the record, it's a great question. Respite care right now is not yet Medicaid reimbursable. My understanding is there are some respite providers across the state, and I believe there may be one in Elko. I don't want to misspeak, but there are a number of providers across this state that are finding grant-funded ways to provide these services in the interim. There's also an ARPA-funded Magellan program called Connect Nevada that provides a number of these services in a grant-funded manner to families. I'm not sure that there are any of their network providers available in the rural communities. And so candidly, that's what we're trying to figure out how we can better support as a state and take on more of that provider network development. It takes time, it takes funding, and it takes relationship building to really help make the case for why this is a new kind of line of service that existing providers could take on, or new providers could join our Medicaid network. And so what we're doing, and that was partially my conversation with our colleagues in New Jersey, although I reminded them that our rural communities, I don't even know if they have rural communities in New Jersey. I don't believe that counts, but it looks a little different here. But we're trying to better understand how do we more sustainably develop a provider network and not just change a delivery system and expect providers to appear. It's going to take a lot more concerted effort, and so that's really what we're focused on right now. But happy to get you a list of specific rural providers that we're aware of right now, if that would be useful to you.
Thank you. Follow-up, Madam Chair? So I also just want to acknowledge, I fully recognize sometimes you feel like you're on a political roller coaster when it comes to some of these issues, not just this administration, but across the spectrum. Every time it changes politically, things change, people come with different ideas. So I just want to thank you for trying to insulate Nevada from some of those and looking at beyond this year, next year, reaching out to 2028, because for families, they really need to have some consistency and at least some hope in the future. So just want to acknowledge all your efforts and thank you, Madam Chair.
Thank you. Next, we will go to Assemblymember Goulding.
Thank you. Thank you for the presentation. To follow up on the question about respite care and rurals, more broadly, we've heard all day and we have been hearing for months about the lack of sufficient providers. So do we have sufficient providers in the state of Nevada to implement this plan?
Madam Chair, committee members, Ann Jensen for the record. I appreciate that question. I think the reality as a state that ranks 51st in behavioral health workforce is we don't have the capacity that we need right now. And that's what we need to build over the next 5 years and in the years ahead. What we've done over the past 2 is get a better sense of how do we support our providers that we have right now. We've seen increased utilization of behavioral health services because of some of those rate increases we've provided, and so that's one lever that we have. We also are partnering with our colleagues and other agencies that have grant monies that can be helpful. I think our provider workforce initiatives and the rural health transformation will all be helpful there, but I think it's going to take that constellation of efforts to really get us there, because right now, to your point, we do not have every single provider that we'll need to be able to serve the needs of our community.
Do you have an estimate of current providers? What percentage do we have to implement the plan at this point?
Yeah, Madam Chair, committee members, Ann Jensen for the record. I think it's a really complicated question to answer and something I'm happy to take back to our data team to try to find some ways to look at it from different angles. Candidly, every child is going to need a very different array of services, and we have what you'll see reflected in that presentation is a different type of provider for each one of those services. And so I think for example, outpatient therapy or residential treatment, we can get you numbers right now on what our current kind of utilization is. The challenge is we don't always know or have an ability to measure unmet need, right? I think there's oftentimes folks aren't even engaging in the system because they don't believe there's access. And so that's a challenge, a continued challenge for us to measure. But I'm happy to take it back to our data team to think through, for all the providers that we do currently reimburse, how many do we have right now? How many children are served by those providers? And do we have estimates of what it would take to continue to meet that need? If that's helpful, happy to adjust that to meet your question as well.
Thank you. I don't see any other questions. I just want to say thank you for your hard work. I know that 42 state plan amendments and 5 federal agencies working with our Medicaid department is it's quite a task, and so thank you for championing those efforts as we really work to provide the highest quality of care to all of our citizens, but moreover our kids. And so really I just want to say thank you for that. Okay, thank you for your presentation. We're going to move to the next item on our agenda, overview of the sequentennial intercept model and how individuals with mental and substance use disorders move through the criminal justice system. Thank you all for being here and for waiting all day with us and wearing your green today for mental health awareness. Take your time. You may begin whenever you're ready.
Good afternoon, Chair Brown, May, and members of the committee. For the record, my name is Amy Sjogren. That's S-H-O-G-R-E-N. Delighted to be here today in my new role as Deputy Director with the Department of Human Services. I'd like to thank the Chair, along with my colleague, Administrator Rivers, for giving me just a few minutes this afternoon to talk a little bit about some education around the Department of Human Services. As I believe we are all very aware of, especially in this committee, is SB 494 from the 25 session reorganized the Department of Health and Human Services and gave us the Nevada Health Authority along with the Department of Human Services, two very separate and distinct agencies that work very well together. Quickly on that, the Department of Human Services is led by Director Laura Rich, who happens to be with us today. And essentially, we provide direct social services, community services to Nevadans of all ages and a variety of disciplines. And just real quickly, and I know that we are at the end of our day, I wanted to touch base on the 4 divisions and which are part of the department. They include the Aging and Disability Services Division. Essentially, that's going to be for aging and those with disabilities. We really want them to have independent and meaningful lives and in the most appropriate setting for them. Also, the Division of Children and Family Services. So essentially, DCFS is going to be providing support and services to assist Nevada's children and their families really to reach their fullest potential together. And you'll hear a little bit later from the Department of Public and Behavioral Health. Essentially, they are protecting, promoting, and improving physical and behavioral health for Nevadans. And lastly, Division of Social Services. They are providing a variety of support services. You've heard a lot lately about SNAP, so that's going to be our Supplemental Nutrition Assistance Program, as well as TANF, so Temporary Assistance for Needy Families, as well as they do provide some preparation for workforce development. How do people get a job? How do they keep a job? What does that look like for them? And then just lastly, wanted to talk about kind of the intersection of where the Department of Human Services and the Nevada Health Authority work together. You heard Administrator Jensen speak a little bit about it in her presentation, but really there's an overlap in Medicaid. Obviously, Medicaid is a payer source, so the services the Department of Human Services provides, Medicaid is a payer. Office of Analytics, where some of the data components come in, as well as there's some social services that the Department of Human Services oversees, and the Nevada Health Authority has some of that funding and regulation behind it. So in a nutshell, those are some high-level things that I wanted to talk to you about today. DHS and the Nevada Health Authority continue to collaborate. Director Rich, along with Director Weeks, are in collaboration, I would say, on a daily basis, as well as the different team members to identify what's happening. So thank you so much. I am going to yield my time back to Administrator Rivers and the rest of the team, and I appreciate your time. Thank you.
All right. Thank you, Deputy Director Sjogren. We appreciate your overview of DHS. Good afternoon, Madam Chair, members of the committee. For the record, my name is Andrea Rivers, R-I-V-E-R-S, and I serve as the Administrator for the Division of Public and Behavioral Health within the Department of Human Services. I'm also joined at the table today by Statewide Forensic Director Drew Cross and Behavioral Health Wellness and Prevention Chief Shannon Bennett. Anytime we have the honor of presenting before you, we always like to ground ourselves in our mission, vision, and purpose for DPBH. So we always like to include that slide of who we are and what we do. Our agenda today, we're going to be walking through a few items, and we're happy to stand for any questions you may have after our presentation. But we have 4 items for today. So we'll just jump into it because we know we're the last of the presentations today. But DPBH works to address root causes like mental health and substance use challenges in the community to reduce recidivism and criminalization of low-level offenses, as well as establish the ideal behavioral health system of care. With that, I'm going to turn the presentation over to Shannon Bennett.
Thank you so much, Administrator Rivers. It's a pleasure to be with the committee today. My name is Shannon Bennett, as Andrea mentioned a few moments ago. I want to talk to you a little bit about the behavioral health system of care in Nevada, which is designed to prevent avoidable deaths and reduce taxpayer burden by coordinating funding streams and improving access to treatment. When we look at the system, it's really made up of these 3 primary funding sources, which is our state-funded programs and facilities that serve as the backbone and the public safety net. And this includes the state hospitals, 988, and programs that serve regardless of the individual's ability to pay. It also includes insurance reimbursement ranging from private insurance, Medicaid, Medicare. All of those things play a large role in expanding access and reducing reliance on the limited state resources. We also have grant and state-funded community-based programs that fill critical gaps that insurance cannot cover, and that works to build out the continuum of care. All of these components work together that build out our behavioral health system. We're going to have a conversation with you today about the sequential intercept model here in just a few moments. And the point of our conversation with you today is really to discuss how important early intervention, crisis response, and the access to treatment are in the system. A coordinated system reduces the fragmentation, which can improve outcomes of Nevadans. So we would like to share with you some information about the sequential intercept model in Nevada, specifically focused on the adult population. The sequential intercept model it's a model that we use with our community partners across the state to look at how different programs fit into this model to keep folks out of the criminal justice system. And we talk with you a lot about our programs throughout these various opportunities, and this is a slightly different way of looking at things, really with that lens on early intervention as quickly as possible. You've even heard some of our community, I think Washoe County regional coordinators spoke about it a few moments ago, that worked on some sequential intercept mapping in Washoe County, and you'll hear that across the state. Really looking at, they use it as a tool to see what programs may be able to be put in place within a community to be able to prevent people from being in long-term care. Go ahead and go to the next slide. We're going to talk a little bit about each intercept and some of the programs that we fund from the state level in each one of these intercepts. The first ones are intercept 0 and 1. So this is really interaction with any law enforcement or that very initial interaction with law enforcement. Our goal is to keep people out of the criminal justice system at all. So this is called deflection. And that's what 988 and the crisis response system is all about. So in Nevada, this may specifically look like access to 988 services, wraparound support, and follow-up services provided by the certified community behavioral health clinics, mobile crisis teams, whether they have or do not have law enforcement involvement. We have both in Nevada, and both work to keep people out of the criminal justice system. And then, of course, we have our crisis stabilization centers in the state as well. I wanted to point out before we move on that there was a study that was done and released in April that indicated that 988 across the country is linked to 4,400 fewer deaths in adolescents and young adults in the first 2.5 years after implementation. We're very, very excited about that information for the country and for us here in Nevada as we continue to see the 988 uptake across the country. and across the state. And one other thing I wanted to mention before we move on to the next intercept is that we work very closely with our community partners. Specifically, we've been really digging deep into mobile crisis response. And I heard some of our other presenters throughout the day talk about this as well. But many of our mobile teams help stabilize people in the short term in our communities. And I think this is one of the struggles that we have, is that we don't have access to long-term stabilization like an assertive community treatment team or something of that nature. And there's a lot of reasons for this, primarily capacity for Nevada, as you've heard a lot about today. And it's challenging to set up this crisis response system without those longer-term stabilization programs in the state. Moving on to Intercept 2, we have a wonderful partnership with 8th Judicial and a couple different programs you're going to hear about today. This one in particular is a jail depopulation program, working in their co-occurring court, or in their court depopulation program, working in their felony DUI, family treatment court, veterans court, and their gambling court. And really this is taking folks who are in jail, who are specifically eligible and being referred to with their probation officer, their judge, and their public defender, and helping them get into transitional housing for treatment and to come back into the community. We also fund programs in various communities that are our FAST programs, or Forensic Assessment Service Triage teams. And these folks provide, and you're going to see them pop up a couple times in this presentation, but these folks provide services within the jails to help get resources to people as they are coming out of jail at various points. With that, I'll turn it over to Drew.
Drew Cross for the record. Thank you, Shannon and Administrator Rivers. And thank you, Chair and members of the committee, for this opportunity to discuss forensic services within the sequential intercept model. Forensic services take place in step 3 of the sequential intercept model. For certain individuals, the question of competency may come up during their court hearings. These individuals will be evaluated, and if found incompetent, they will be committed to the Division for Competency Restoration. These individuals will receive competency restoration either on an inpatient or outpatient basis through the state forensic hospitals. This intensive process involves a multidisciplinary team, treatment, legal process education, and clinical support services. This process culminates in an evaluation that will be submitted to the court, opining if the client is competent or incompetent. Now we'll discuss jail-based restoration and diversion. During the 83rd legislative session, and with the passage of Assembly Bill 467, jail-based restoration became permitted in Nevada. This allows for select individuals committed to the division to receive competency restoration services in select detention centers. While the inpatient setting is available for those who are most in need of intensive psychiatric services, we also offer diversion for individuals who are found incompetent, have lower-level, nonviolent charges. These individuals are diverted from the inpatient forensic restoration services into a more appropriate level of mental health care in the civil system. This has the benefit of providing care in a timely manner in a targeted, community-based setting with wraparound services which can help to break the cycle of incarceration. These diversion opportunities are an appropriate alternative to having an individual occupy an inpatient forensic bed, which allows these beds to be reserved for the more psychiatrically acute individuals with serious charges. Thank you for allowing me to address forensic services within the sequential intercept model.
Thank you for that. And this is Shannon Bennett again for the record. Moving on to intercepts 4 and 5. Intercept 4 involves supported reentry back into the community after jail or prison to reduce further justice involvement of people with mental and substance use disorders. In Nevada, this looks like transitional housing, which we certify within the Bureau of Behavioral Health, Wellness, and Prevention and fund. We also work with 8th Judicial again to do similar work where they hold transitional beds and refer people to those transitional beds. And again, our FAST teams play a role in this as well. As folks are coming out of jail and re-entering the community, they're providing resources. Intercept 5 involves community-based criminal justice supervision with added supports of people with mental and substance use disorders to prevent violations or offenses that may result in another jail or prison stay, which we work with 8th Judicial on as well. And last slide, we just wanted to mention some opportunities as we continue to work on building out our behavioral health system of care. The sequential intercept model does help us visualize where investments can be made and to have the greatest impact. And every intercept represents an opportunity to reduce unnecessary justice involvement, improve health outcomes, and strengthen public safety to ensure Nevadans receive the right care at the right time. We do have an access to care challenge. You've heard a lot about that today. There's a lot of reasons for that, but of course, that is something that pops up every time we do any community needs assessment or strategic planning is access to care. We are continuing to work with our community partners to integrate 988 to de-escalate as soon as possible. We also see the need, as I mentioned at the beginning, for more long-term community stabilization so we can stop people cycling and stabilize them instead within the community. Needing, and heard some about this earlier today as well, some enhanced step-down approaches for longer-term stabilization, perhaps housing supports and similar. We look forward to continued collaboration with re-entry initiatives. Nevada Medicaid has a re-entry waiver that they're applying for, I believe, that we're very excited about. Continued investments in peer recovery supports. We strongly believe, and through some strategic planning that we've done in the last year and a half or so, peers are essential to our behavioral health system here in Nevada. They have a saying that our federal partners at SAMHSA say, which is nothing about us without us. We should not be building a behavioral health system and working on a behavioral health system without our peers. And we work closely with the Nevada Certification Board and others to really ensure peers are implemented across all of our programs. We also see opportunity to standardize our crisis response and intervention training to ensure that our mobile teams that are going out in the field are supported with the proper training and are connected into their community in a way that is standardized across the state and tailored for each community. So with that, I'm happy to take any questions the committee may have, and it's a pleasure to be with you today. So thank you for the opportunity.
Thank you. Thank you for the presentation. Thank you for waiting with us all day long. Senator Titus.
Thank you, Madam Chair. And again, thank you for being here. I'm curious about a comment on page 14 about intercept jail-based programming 3, where you do a competency and whether they're competent or not. What happens if you decide they're not competent? Where does that go then? What do you do with these folks?
Drew Cross, for the record. Madam Chair, through you to Senator Titus, thank you for that question. Typically what happens when someone's found incompetent is an assessment is done for civil commitment. This is for lower level charges. A determination will be made if the discharge plan needs to be facilitated for that individual to safely integrate them back into the community with those charges being dropped. If they happen to be dangerous at that time, we do have the civil hospital available where those individuals can be civilly committed and seek additional treatment.
Well, I'm worried, follow up if I might, if they're not competent and it's a lower level charge, how can you possibly discharge them anywhere if they're not competent?
Drew Cross, for the record. So there is a differentiation between the more egregious charges and the lower level nonviolent charges. So for a more egregious felony charge, the 178461 statute comes into play, where an incompetent individual facing an egregious felony will be assessed, given a risk assessment by one of our trained clinicians to determine if a 10-year commitment would be appropriate based on their charges and their history. So with those individuals, they would be in the state hospital for a 10-year commitment. We also are careful to triage cases that are potentially 46-1able to the state hospital to avoid this scenario. So if an individual has a qualifying charge, that person would typically go to the state hospital.
Okay, thank you. Next question, I guess, is I'm seeing that you have a pretty good relationship. Washoe County certainly has implemented a very impressive jail-based program, and Clark County has some certainly some programs and an access. But what about all the other 15 counties? And where do they go? And we heard earlier today about being discharged potentially from a jail at 2 o'clock in the morning. What does it look like for the rurals?
Drew Cross for the record. Madam Chair, through you to Senator Titus. Great question. Our rural partners are incredibly important, and we don't want them to be lost in this process. And just recently, under the leadership of our administrator, we've had extensive reach out. This includes meeting with the various judges of the courts. That was about 3 weeks ago in Las Vegas, where we were able to interact, gain contacts, and allow them to benefit from our diversion program, which entails our jail liaison going to the county, assessing individuals who are in the pipeline for forensic services, and seeing if an appropriate alternative could be found. This is for individuals that are nonviolent that could be safely integrated into one of our civil wraparound services. We're also facilitating, I think currently, some of our rural counties are actually touring the inpatient setting to get an idea of what's taking place. Where jail-based restoration can also benefit our rural partners is the footprint decreases for the counties that utilize jail-based restoration. So Washoe County, those beds that would have typically gone to Washoe are now available, and we have seen a reduction in our rural wait list. So it's helping all of our partners. The big thing that we're doing with our rural counties is we're making sure we're there to meet them. We met with the sheriffs after we met with the Judicial Committee down in Las Vegas. There was a meeting, I think, about 2 weeks ago in Carson, where they were able to share with us the concerns about their population, and we were able to put them in touch directly. We brought our jail liaison with us. They were able to exchange contact, and this has resulted in successful diversions for our rural counties.
Just a comment. Thank you for that, because they really try out there. I've taken a tour of the Esmeralda County Jail, and I've been, I represent Esmeralda County. I've been at Tonopah, and it's really a concern. One person that meets the criteria for not being competent or disruptive in those small counties is a dramatic drain on their resources. So making sure that they have like a speed text to some help from the state is good to hear. Hopefully that can be expanded. Thank you, Madam Chair.
Thank you. I'm going to ask you for clarification. There seems to be a little confusion. You did say 10-year, not 10-year, correct? So if an offense would be potentially punishable by a term of 10 years, is that what you're referring to in that statement?
Yes, so in NRS 178461, it's a 10-year commitment.
Thank you. We didn't know if we had clear hearing. I appreciate that clarification. Do you have a question? Are you good?
So that 10 years is if found guilty, one would have been incarcerated for 10 years? I just want to make sure that we're not just. Can you?
Yes, Drew Cross for the record. Madam Chair, through you to Assemblymember Golding. Great question. So the 10-year commitment is reserved for egregious felony level charges, and every year an annual risk assessment is produced for those individuals and submitted to the courts. It's not a definitive 10-year, it's allowable for 10 years, and it can be recommitted for 5 years after that initial tenure, but every year this is visited. Every year our clinicians are generating a report to the court, and if the client is appropriate, we do have programs such as conditional release, which is under 178463, where these individuals, under our supervision, remaining committed to the division, can be placed in a safe environment in the community and reintegrate.
So if they're treated at the forensic hospital and found competent later, are they then do they go through the court system, and are they tried then?
So under the commitment of 178461, the charges are dismissed without prejudice. So that's no longer in play. If they were found competent prior to that point, they would proceed with their their criminal trial.
Thank you for that. We're all learning the judicial system, forensic hospitals, and mental health care, and so we appreciate you doing that. There was a comment earlier this morning in public comment, and I don't want it to go unnoticed. And so I know, Director Rich, you're here in the room with us, that there were statements about safety of some of our staff in the state-run facilities. It was specific, I believe, to youth mental health forensic services. I'm wondering if you could just give us a brief update on where you are relative to that current situation that you're addressing? Yes? Oh, Kim. Oh, good. Kim is there. Thank you so much. Ms. Abbott, if you don't mind, that would be great. Thank you.
Good afternoon, Madam Chair and committee. Thank you for having me and giving me the opportunity to address the comments this morning. We are very aware of the concerns that were raised regarding staff injuries at Desert Willow Treatment Center. And I want to be incredibly clear, the safety of our employees, as well as the well-being of the youth who are entrusted to our care, is our absolute highest priority. Physical restraints and resulting injuries to youth and staff have been a concern at Desert Willow, but the last few weeks have been particularly challenging. There have been a number of incidents where staff have restrained youth or attempted to restrain youth, and in the process, injuries have occurred. Our leadership team has been carefully reviewing these incidents and determining whether some of those interventions were appropriate. In some instances, that level of restraint may not have been warranted, and escalations occur, and then unfortunately, we end up with injuries. We also had the incredibly unfortunate incident that you heard about this morning, where a young adult on our competency restoration unit did violently attack and injure a staff member. And these incidents are deeply concerning, and we are approaching the situation with the seriousness, the urgency, and the accountability that it requires. We've already initiated several immediate actions to try to stabilize operations and strengthen support for our staff who are working in these most challenging environments. Efforts already underway across our hospital include the following. HCQC, our licensing authority, had actually previously arranged for an assessor to come out and to review our policies and practices and to provide us with guidance and support to help make sure we are on track in providing appropriate care. Dr. Brown and her team from Quality Healthcare Asset Management, their group of 10 staff arrived last Monday, and today's day 8 that they have been with us throughout the entire hospital, observing across different shifts, reviewing patient care processes, policies, and they are going to be making recommendations for corrective action and improvement across the entire hospital. In an attempt to ensure order and safety on the competency restoration unit that you heard about this morning, while we're working to put some other solutions in place, we have on a temporary basis began having some of our staff from Summit View, one of our juvenile justice facilities, some of our group supervisors have been helping to cover some evening and weekend shifts when there's less structure on the unit. They have additional expertise and skills in working with the juvenile justice population. We're also restructuring our staffing plans to make sure that we are better distributing experienced staff across all of our shifts and high needs areas. We've been reviewing our training, operational practices, supervisory coverage, and safety measures to strengthen our staff safety, visibility, and situational awareness. We also have been working through DHRM and the governor's office to convert some positions that we had vacant into additional leadership positions that we believe will help quality assurance specialists, additional clinical program managers, and clinical program planners. We are also strengthening our approach by emphasizing a shift towards proactive therapeutic engagement and prevention rather than relying on physical interventions. We've increased the structure of the activities that we're offering to youth throughout the day and across the milieu. Additionally, we've increased the staff's focus on building rapport and structured engagement with youth throughout the day, including adding additional therapeutic groups and activities facilitated by our clinical staff. Just on Saturday, we had an additional de-escalation training that a number of our staff participated in. We are continuing to work collaboratively with our union partners. In fact, about a week and a half ago, we had a 2+ hour meeting with the union. It's important to us to have an employee management board as we move forward, so we can improve communication, we can increase operational flexibility, and we can ensure that employees' concerns are elevated and addressed quickly and constructively, and that staff input is taken into consideration as we make changes and decisions, because they are the on-the-ground experts in working with these youth. Additionally, moving forward, we have several things that we want to work on that we believe will help enhance safety throughout the facility. We are planning to implement a major change to our staffing structure to ensure that we provide more clarity about supervision, coaching, and more therapeutic supports for all of our staff who are working with youth. We are looking at the possibility of adding a response team that would not be assigned to a particular unit, but that would be available to respond to codes. We are ensuring we have adequate staffing across all shifts and ensuring break times are scheduled and that appropriate coverage is available, and looking at reducing overtime and double shifts. I know there were some comments this morning about staffing across shifts. I did pull some numbers to look at our staffing ratios as I've been sitting here today. The best practice suggests on a base level 4-to-1 staff ratios, and that is what is written into our policy at Desert Willow. We run significantly over that at all times. When I looked at all of the staffing for every shift in May, most of those shifts we were 1-to-1. Some of them we were over 1-to-1, one staff per child that was on the unit. There were a number of shifts where maybe 5 staff to 6 youth, 4 staff to 5 youth, but very high staffing ratios compared to what is, I think, the national average and what is our own policy. We are also working, and this is a really important one to me, to ensure that we are consistent in our implementation of all of our policies and our training to make sure we're supporting that, as well as consistent accountability and more quality assurance measures. We are also working to better support and communicate expectations with our mental health techs to ensure that they can follow through with some of the education available and the ability to auto-progress up into mental health tech 2s and 3s with enhanced education and skills. We're also looking at implementing and updating our uniform and dress code policy to sort of up our level of professionalism in the hospital, as well as to be able to help all of us better identify the different levels of staff and supervisors and leadership in the hospital. Our senior psychologist is in the process of developing an interactive trauma-informed training that she's going to put on May 15th. And all of our staff are going to be attending a additional trauma-informed training on May 18th to help give them additional tools and alternative ways to engage with youth. There are a number of things that have contributed to the current unfortunate situation at Desert Willow, including a lack of strong leadership, a lack of adequate resources and oversight, and inconsistencies in training and supervision and accountability. And then, as you heard this morning, further, last summer, we, pursuant to the new legislation, had to make a major change in the hospital. We had to shut down our acute unit, turn it into this competency restoration unit. The type of services and the behavioral interventions that are required on this unit are very different than those we have traditionally provided at the hospital and those that are traditionally provided in residential treatment units, as the needs of this population are not the same. And given the juvenile delinquency allegations involved, the level of aggression and the challenges in behavioral management can be significantly higher than on our other units. So based on the complexities and the challenges presented by this competency restoration unit as well as we're expecting forthcoming recommendations from the management asset team that is currently evaluating Desert Willow. I imagine we will be asking for additional resources as we move forward into the next session to be able to support safety for both the youth and staff on our various units. Our responsibility at Desert Willow is twofold. It's to provide a safe working environment for the professionals who are serving in these challenging roles, and it's to ensure that the youth in our care get safe, appropriate, and effective treatment. We are fully committed to both of those obligations and to taking the necessary actions to improve the conditions and to support our workforce so that we can strengthen operations at the hospital moving forward.
Thank you. Thank you. That was very comprehensive. I appreciate the level of detail and your thoughtfulness in providing that information. Just to follow up on one of your statements relative to staffing ratios, I appreciate that. And as I have discussed in many instances, it's not always the numbers that are the solution, right? And sometimes overstaffing can also contribute to an adverse condition, right? And so staffing levels should be appropriate in order to meet the need, but are not always the issue. Is it training, and is it awareness, and are we, appropriately paying attention to the situations that are in front of us? In my experience, overstaffing sometimes means you're not paying attention to the people in your care because there are too many staff that are having fun, right? Not that there's anything wrong with having fun, but it's easy to get deterred from the mission at hand when there's ample hands. And so I just say this as a matter of understanding the level of care in this type of facility that's necessary, and that a balance is probably our best approach. I appreciate that you are working in that direction. I don't believe that we've ever gotten a report quite so quickly relative to an issue that presented itself in the morning that we have just become aware of within the last week. And so I'm grateful for this team, this new team, that's really working to pivot and change the way our state responds to a high-need population. And so I want you to walk away with that. Thank you for responding to such serious situations so quickly and safeguarding not only our youth who have a high support need and adults, but also our staff, that way they can go home to their families at the end of the day healthy and well balanced. So I appreciate you, and I want you to hear that as we continue to work through this very dynamic situation that we are experiencing currently. Are there questions from members? No. Thank you. I appreciate that. Thank you so much for your presentation and for being with us today.
Thank you, Chair. My pleasure.
That leads us to the next item on our agenda, which is public comment. So we will start with public comment for those in physical locations. If you would like to offer public comment here in Carson City or in Las Vegas, please come forward. Take your seat at the testimony table. I see no one. Oh, I do see one. Thank you so much. Go ahead, take your seat. You may begin whenever you're ready.
Good afternoon, Chair and members of the committee. Cassie Charles on behalf of AFSCME, the American Federation of State, County, Municipal Employees. I know this committee heard very clearly from our members this morning and the concerns that they have, and we appreciate the report from the agency on what they are working on and how they are working to improve the safety and conditions at Desert Willow specifically. I do want to be clear and ensure that this committee is aware that concerns are coming from members at all of our state psychiatric facilities. This is not isolated to Desert Willow. Of course, our conversation today was specifically focused on Desert Willow because of the incident that we heard of and became aware of last week. But we have a lot of work to be doing in our state psychiatric facilities, and we look forward to working with the agencies on ensuring that our workers are adequately prepared and staffed and safe on every shift. So thank you.
Thank you. Thank you for still being with us. Seeing no one else here in physical locations, AVH, is there anyone on the telephone line who would like to offer public comment? And before you call for that, I will just repeat the telephone number. So anyone who would like to dial in, please dial 888-475-4499. And then today's meeting ID is 860-2827-5330. And when prompted, press the pound key.
Thank you, Chair. If you would like to provide public comment today, please press star 9 to take your place in the queue. Caller with the last 3 digits 710, you are unmuted on our end. Please make sure you are unmuted on yours.
Thank you. Dear Chair and community members, my name is Chris Doss, for the record. I am a licensed clinical social worker practicing here in Nevada. As a proud lifelong Nevadan and a 2003 graduate of UNLV, I have dedicated my career to the well-being of our community. I'm speaking today not as a representative of any agency or special interest group, but as a frontline provider deeply concerned about the trajectory of our state's Medicaid system. While much of the current public discourse focuses on the impending budgetary shifts following the, quote, big beautiful bill, end quote, I want to highlight a more immediate systematic crisis, the administrative bureaucracy that is driving qualified providers away from Nevada Medicaid. Currently, Nevada Medicaid consistently ranks at the bottom of the national health care scales. We cannot rise to the top 10 if we continue to make it functionally impossible for providers to partner with the state. My concerns, shared by many of my colleagues, center on the following issues. A culture of non-responsiveness. Providers frequently encounter a total lack of communication from state administration. When issues arise regarding credentialing or billing, there is no direct line of communication. The policy barrier. Our third-party administrator, Gaineswell, frequently defaults to the phrase, quote, against our policy, end quote, when asked for clarification on claim denials. Providers are often told that staff are prohibited from explaining how to correct an error or provide contact information for a supervisor. This creates a black box system where providers are set up to fail. Presumption of guilt. While I applaud the state's efforts to curb actual Medicaid fraud, the current approach treats every honest administrative error as a criminal act. Even when a provider self-identifies an overpayment, repays the state, and implements a corrective action plan, they are often still penalized and treated with a presumption of fraud. This guilty until proven innocent stance is both demoralizing and lazy. The result, I've met numerous medical and behavioral health professionals who refuse to accept Medicaid, not because of the reimbursement rate, but because the bureaucracy is simply too difficult to navigate. We need a system that prioritizes transparency, communication, and mutual respect between the state and its providers. If we simplify the process and treat providers as partners rather than adversaries, we can increase access to care for all Nevadans. I would welcome the opportunity to discuss these concerns with you or your staff in greater detail. And thank you for your time and your service to the great state of Nevada.
There are no further callers wishing to provide public comment at this time.
Thank you, AVH. Before we wrap today's meeting, I just want to take one quick moment of personal privilege, and I want to recognize, I'm going to make myself cry, a pillar, a woman that we lost just this last week, Senator Woodhouse. My heart is broken that she is gone. She chaired this committee in previous sessions and is a legacy for us all that we may be able to continue to lead with integrity and the love that she showed every citizen in our state. So, in honor of Senator Woodhouse, we will adjourn this meeting today.